the organizing team, Central NNF organizing team, for giving us the opportunity to organize this advanced echo workshop organized by Andhra Hospitals Vijayawada, Andhra Pradesh. And yeah, well, we have faculty, excellent faculty today. So starting from Dr. Mohi sir, he's from Surat. He's a senior consultant neonatologist. He's gotten a vast experience in the field of neonatology, and he's been teaching and training people in in ultrasound and echo. For so many years. He's a very experienced person. And then we have other faculty as well. We have Dr. Vikram Kunumala. He is a pediatric cardiologist from Andhra Hospitals Vijayawada. He's got nearly 20 years experience in the field of pediatric cardiology. He worked in UK for so many years. He worked there for about 17 years. He worked in all teaching hospitals, including Glenfield Hospital, Leicester, and in teaching hospitals in Manchester. So he has gotten a vast experience in pediatric cardiology. He has gotten a CCT in the pediatric cardiology from UK, and he's been with us with Andhra Hospitals for the past 4 years. And we did so many pediatric cardiac surgeries. We did more than 2,000 pediatric cardiac surgeries in the last 4 years or so. And then so we have another faculty member, Dr. Naveed. He's a consultant neonatologist from KIMS Hospital, Kurnool. He worked in UK for so many years. So he worked in all big hospitals, teaching hospitals in UK, and he's got his MRCP-CH and also fellowship in neonatology. So, welcome, Dr. Naveed. And we have other faculty members, Dr. Bujata, Dr. Buja. She's a consultant neonatologist from Andhra Hospitals Vijayawada. She's got more than 10 years experience in the field of neonatology, and she did so many workshops, and she's well versed with all advanced echo teaching and training skills. Welcome, Dr. Puja. And we have Dr. Revant. He's a consultant pediatric intensivist from Andhra Hospitals Vijayawada. He did his MBBS from AP and MD from JIPMA, Pondicherry. And after that, he did his fellowship in pediatric intensive care. And he's very good at advanced echo, mainly functional echoes, and in identifying shock and other skills. So I think it's good to have so many faculty members, and they're all kind of very experienced, and so I'm sure you'd have some academic feast today. So I think without wasting much time, so we'd start with initial first presentation by Dr. Naveed. And sorry for the delay. There was some network issue, some organizational difficulties, but finally they were there. And there are about 10 people attending virtually. So so we have enough people. Okay, thank you. Thanks all.
Good morning all. Yes. Is that clear? First of all, hello. I first of all like to thank the Central NNF for inviting me to be part of this workshop, and I thank Dr. Ramarao sir for giving me my introduction. So my talk is about basic echo views. It will be like a basic echo workshop, but we'll be quickly running through the views because this is advanced workshop, and I understand everybody would have had hands-on training before coming to the workshop here, but we'll revise through the various views. So as we all know, the heart is not straight like the brain's orientation. So we can't do coronal and sagittal views like we do for the brain. The heart is angled in a oblique angle. So it's angled like this and turned in a position how yeah. So the right-handed structures are actually. So should I? Can I go? So the right-handed structures are anterior and to the left. The right-handed structures are anterior, while the left-handed structures are posterior. The atria lie to the right of their respective ventricles. The ventricles are to the left and inferior to the atria, and left atrium is the posteriormost chamber of the heart. So if you look at it, the heart is oriented this way. So the left structures are posterior. So the heart is the heart is oriented in an angle like this. So the left structures are posterior, while the right structures are to the anterior, and the left atrium is the posteriormost chamber of the heart. Yeah. So the atria lie to the right of their respective ventricles, while the ventricles are to the left and inferior to the atria. They're not straight down, but they're left and inferior to the atria. Left atrium is the posteriormost chamber of the heart, right? So talking about the orientation of the AV valves, again the AV valves again are not, all the valves are not arranged in the same plane. They are arranged in different planes. Aorta is in the center and all the other valves are surrounding it. So aortic valve is central, like I said, and pulmonary valve lies anterior and superior. AV valves would flank inferior margins of the aortic valve, and tricuspid valve is the inferiormost chamber. So inferiormost. So tricuspid valve is the inferiormost, while aorta is in the center and all the other valves are around it. So as you can see in the four-chamber view, the tricuspid valve is more towards the apex compared to the mitral valve. So tricuspid valve is more apical. It is supported in part by the septum. And it is not in fibrous continuity with the outlet valve. The mitral valve is higher up. It is in continuity with the outlet valve, and there is no support from the interventricular septum, and it is supported by two groups of papillary muscles. So as you can see, the mitral valve is not directly in touch with the interventricular septum. So the cardiac chambers, the right ventricular cavity is triangular in outline. It has coarse trabeculations and it has moderator bands. The left ventricle is ellipsoid. It has fine trabeculations and it has got papillary muscles. So if you look at the inflows and outflow tracts, the left inflow to outflow tract is acute angle, while the right one is obtuse, where the pulmonary outflow tract swings to the left and superior relative to the aortic valve. So that's how the crossing over happens. So once you see, you can visualize the crossover of the major outflow tracts. You can rule out a TGA. Yes. So just mention about the Doppler. As we know, any blood approaching towards our probe will appear red. So towards will be red, and away flow will be blue. And when you check the flows, the laminar, we check whether either it's a laminar flow or a turbulent flow. Turbulent flow would indicate any obstruction to the flow. Velocity, when we measure with the Dopplers, we normally use Bernoulli's equation, which is 4r square. So whatever velocity that you get, you multiply with 4 and square the number that we get. Angle of insonation, that is important because when we are doing Dopplers, And in the window, when we drop the line to measure the Doppler, the flow of the blood and the angle of our line should not be more than 15 degrees. Otherwise, we wouldn't get accurate values. And most of our machines have angle correction as well, so that the angle of insolation is as less as possible. So next slide. So this is a laminar flow which is smooth in outline. And as it is downward, it means the blood is flowing away. And the next slide. Sir. Enlarged, normal size, abnormality like hypoplastic left heart or hypoplastic right heart, things like that. So assess the chambers, and then you assess if the chambers are opening into their proper arterial connections. So LVOT and ROT measurements, and whether the arteries are crossing over, the major arteries are crossing over. So that can be done with our subcostal and apical views. Once that is done, we are left with ruling out duct and what is the hemodynamic significance, and rule out any coarctation with the suprasternal views, and whether the pulmonary veins are draining into atria. And then in the end, you can do the functional assessment. Most of the times we eyeball and decide how, with experience we get that, isn't it? So we try to check whether the cardiac output is good, but we have proper assessments as well, which we'll be discussing in the later presentations. So always normal anatomy should never be assumed. It should be proven. So we should not assume that the chambers are opening into their respective arteries and things like that. So we have to prove that by doing the echo. So next we'll go on to the views. Next slide. So these are the views as we know. Subcostal view will be the first view where we establish the situs, and then apical view. Parasternal views are two views, so long axis, short axis views, and then we have the high parasternal view or the ductal view, and then the suprasternal view. So we'll go on to the subcostal view. Next slide. So the first thing, like I said, was to establish the situs. So when you are holding a probe, so first you hold in the, so you have a pointer on top on the probe. So just put it in the 12 o'clock position. So straight down, yeah, straight down. And you can see, just next slide briefly. Oh, sorry. So we can see that's the spine, and that's the aorta, and that's the IVC. So aorta is to the left of the spine. If you take this as a midline, this is aorta to the left, which will be pulsating, and then on the right you will see the IVC, and this is all the liver. So that view should come first before we start going further, because if it's situs inversus, everything gets mirror image, right? So we have to make sure that it is situs solitus, and then you assess your IVC, the collapsibility of the IVC. So once you do in the 12 o'clock position, then just tilt to the left, to the right, and then to the left. So to the right, you assess your IVC, how if it's dilated or collapsing or not, if baby's volume depleted, things like that, to assess your IVC. Then if you tilt to the left, you will see your aorta. So that is you checking your IVC. That's the IVC. And so if you tilt towards the left, you will see your aorta. In the aorta, you can see your SMA and celiac artery. And that is the UAC here. You can even do the Dopplers there to measure if there is any significant effect of a PDA. If there is a diastolic steal, you can do the measurements. So in the bottom line, you can see the Dopplers. The left one is a normal Doppler. The right one is where there's absent flow in the diastole, absent flow in the diastole here, and then you have a reversal here, so diastolic steal is significant. So things like that can be assessed. If you're not able to get proper access of the aorta, descending aorta, you can even do on the celiac or the SMAs. So here the blood will appear red in color because it's approaching the pointer. The pointer is on the top, and these are your arteries. It will appear red. While in the descending aorta, you normally see a blue Dopplers. So after doing those three things, then you assess the atria. So after doing your these positions, 12 o'clock positions, you go on to the 5 o'clock position. The pointer pointing towards the down. So 5 o'clock position, and then you look up. You will see the atrial chambers, right? The heart is oriented in an angle this way. So the posteriormost are the atrias. The ventricles are slightly anterior. So when you put the pointer in the 5 o'clock position and look down, you will see the atria first. Then you start tilting forward. Yeah. Then you see your ventricles. Then you tilt more forward. You will see the aorta. More forward, you will see the right ventricular outflow tract. Yeah. So you just have to tilt your probe upwards. Yeah. To see all the chambers. And when you are seeing the atria, you will see that the SVC is opening into the atria, so that you establish that the IVC. You can assess the pulmonary veins briefly, and then assess your ventricles, and then arterial crossover, like I mentioned. Here you are looking at the two atria, left atrium, right atrium, and this is the PFO. You can measure the PFO, you can measure the Dopplers. The PFO flow should always be red, which means the blood is flowing from the left atrium to the right atrium. When in pulmonary hypertension, you might see a bidirectional flow, but if you're seeing the totally blue flow there, that you have to think about TAPVCs. So it's very unlikely that you will see the totally full blue jet if it is not TAPVC. This is another view of that. Right. So once the subcostal views are over, so in subcostal view, like I said, you assess the atria first, then you can assess the two ventricles by tilting forward. In the ventricle, you can assess if there is any ventricular septal defect, how the chambers are. Then you tilt forward, you will see your aorta going from the left ventricle, so LVOT. See if the velocities are okay, if the opening is okay. This your right ventricular outflow tract. Yeah, and the arterial crossover is also can be checked. In your assessment of the left atrium, you can even check for pulmonary veins. So most of the major cardiac anomalies, except your checked with um, subcostal views. That's the God's gift for us when you're doing neonatal echoes. In the fourth chamber, then you go on to the apical view. Once you finish the subcostal, you go on to the apical view. So, four chamber view. So in the apical view, we can assess the four chambers, assess, then check for the offsetting of the AV valves. Like I mentioned initially, the tricuspid valve is more apical. It is attached to the interventricular septum. Um, but you decide the tricuspid valve, that is the right ventricle. Yeah, the AV valve goes with the ventricle and not with the atria. So decide whichever is the tricuspid valve, and that is usually your right ventricle. And there are other features how you differentiate right and left ventricle. Like in the left ventricle, you see papillary muscles; it's less trabeculated, while the right ventricle is more trabeculated with moderator bands. Sir? That's it. And then you in the fourth chamber view, you have MR and TR, you, and then the interventricular. Once you tilt a bit forward, in the five chamber view where you see the aorta coming into view, and assess your LVOT followed by RVOT. So that's the four chamber view, so with all the four ventricles, and you can see that the tricuspid valve is more apical. That's your interventricular septum showing a VSD. So we can assess the four chamber anatomy and abnormalities, TGA and PDA and its effects, like whether it is LA dilatation and all things like that. So we'll go on to the next view, is the parasternal long axis view, where you put the probe in the 11 o'clock position. Yeah. Um, so pointing this way, because the heart orientation is this angle. So if you're cutting it this, putting the probe this in this angle, you will get the long axis of the heart. So this is a text taken from one of the textbooks. So that's the long axis. So if you're cutting the heart like this, that's the long axis of the heart, and usually presented upside down. So the atria are towards the right of the image, while the ventricles are to the towards this side, towards the left. In the parasternal long axis view, like I said, it's the 11 o'clock position of the pointer, and in the upper two-third and lower one-third of the sternum. Once you once you tilt your probe downwards, you will you will see the entry of the right ventricle, so inflow of the right ventricle. When you tilt upwards, you will see the outflow of the right ventricle. So those two tilts you have to do while you are doing the lower tilt and upper tilt. So where you assess the tricuspid regurgitation, and you can assess the main pulmonary artery. And any perimembranous VSDs can be picked up in these. And then you can do the M mode where you can assess your PDA and effects of the hemodynamic significance of the PDA. This will be discussed in the next one, presentations. And you can also assess the fractional shortening. So this is a view. So interventricular septum, the right ventricle, the left ventricle, and the aorta opening there. So these are the mitral valves, and this is the aortic valve. So here you can pick up any perimembranous VSDs. For M mode, for LAO ratio, you draw the line here, and you can do the M mode to assess your LAO ratios. So then we move on to short axis. So where you tilt your probe position from this 11 o'clock position to this position, because the heart's short axis is in this angle. So again, I've taken the pictures from one of the books. Um, so you can do multiple short axis cuts, and then you get pictures like this. So that's the aorta in the center, and the whole heart wraps around the aorta. So these are the aortic valve leaflets, which you see as a Benz sign or Benz sign. So 3 leaflets of the aorta, and then RVOT. Uh, right atrium and left atrium with the interatrial septum, and then you can see the RVOT opening into the LPA and the right pulmonary arteries. So as you do the cuts, you can see um, coronaries there. Here you can see the coronaries opening. If you go more further down, you can see the mitral valve, fish mouth shaped mitral valve, and further down you can just see the papillary muscles of the left ventricle. Yeah, you can assess the interventricular septum and things like that in the short axis cuts as well. So that's the image with the aorta in the middle and the heart wraps around it. You can't see the right atrium in these views. Yeah, you can see rest of the 3 chambers. This is the further down where you can see the papillary muscles, like I showed in the images. These are the two papillary muscles, left ventricle and the interventricular septum bending, bowing into the right ventricle. When in pulmonary hypertension, you can see flattening of this interventricular septum. Yeah, so they should be curved into the left ventricle, right ventricle. Then you go on to the suprasternal views, which is the 12 o'clock position. So this is the assessment of the aorta. So you can see the aorta with these three branches and the right pulmonary artery here. So aorta wraps around the right pulmonary artery, ascending aorta and the descending aorta. Then you can put the Dopplers and measure the velocities. And if there is any doubt about coarctation and things, you have to assess in that suprasternal view. Then high parasternal view, which is one space, second to third intercostal space on the left side, the pointing towards the 3 o'clock position. The ductal view. So you can assess the size, flow of the duct, and you can assess the LA-AO ratio and the diastolic steel. So that's the three-leg view, right pulmonary, left pulmonary, and the PDA. So this is the main pulmonary artery, and this is the aorta. So the blood will appear red because it's flowing towards the, from the aorta to the main pulmonary artery. Because the pointer is on the top, the blood approaching towards this pointer will appear red in color. So if there is pulmonary hypertension, you might see the other way around, the blue color or bidirectional flow. So this is again the duct. There's slight turbulence here because you can see blue as well here. As the duct narrows, you might see more turbulence. So various, I think, views of the ductal flows, I think, will be covered in the PDA presentation. I'll skip through this one. So crab view that we say, which we assess for the assessing the pulmonary veins. We can see a bit of pulmonary veins when you're doing the subcostal view, when you're looking into the left atrium. But crab view is the best one to assess the pulmonary veins. In the parasternal long axis view, we put one or two space higher and angle it inferiorly so that it hits the pulmonary artery in the long axis. So that is the crab view, because the one pulmonary vein here, one pulmonary vein here, so right side, the left pulmonary veins, lower one and the upper one here. So we can see the four veins. It appears like a crab. That's why it's called a crab. So those are the two pulmonary veins that you can see. The approaching these two veins will appear red. The other two veins will appear blue because they'll be going away from the pointer. So I think I'm just trying to show the TGA here. You can see two parallel flows. Normally I mentioned about the arterial crossover. Normally this should go in this angle and this should come the other way around. So they should be at 90 degrees to each other, but here they are doing parallel circulation. So that's the TGA. So I've come to the end of my presentation. So we have to do segmental approach, like I said, first establishing a situs and then going to the atria, ventricle. So do a segmental approach. Always establish normal anatomy. Never assume the normal anatomy. It should be proven by our findings. And any abnormal finding that you see should be reviewed by a cardiologist. Yeah. Thank you.
Hear me? Yeah. Okay. My name is Vikram. I am a pediatric cardiologist in Andhra Hospitals. I would like to thank the organizers for giving this opportunity. And it was a nice presentation by my predecessor. He covered all the standard views, how to get it, and we'll start from there. Okay. And I would like it to be more interactive. I got all the case scenarios that you come across as a neonatologist. So it will be good if you come forward and so I will show you the echo views. So now you know how the normal heart looks like, with the first presentation. With this presentation, I will show the echo views with common abnormalities you find as a neonatologist. And please shout at the findings so that we can get the diagnosis. Okay. So it will be more interactive so that it sticks to your mind. Okay. So thank you. Okay. So as you all know, my talk is on what is the role of neonatologist. What they should know about congenital heart disease to diagnose it in right time. So congenital heart disease, as you know, is the most common congenital anomalies with incidence of 18,000 live births. And among these, critical congenital heart disease are those who needs surgery or intervention within 1 year of age. So they constitute 25% of total congenital heart disease, which is a significant number. Okay. So the main issue here is the delay in diagnosing these critical congenital heart disease will increases the survival, affect the survival rates even after surgery. So the role of neonatologist is here to diagnose these babies with critical congenital heart diseases in a right time, without any delay, without they become unwell, so that they will have very good outcome. Because most of the cardiac surgeries at this moment in most of the centers, they got survival rate up to 98% and they can lead normal life, except these univentricular heart. Most of the heart diseases have very good outcome. But the key thing is to diagnose them early. That is the key thing. That's where the role of neonatologist is, to diagnose them in the right time. Okay, because the pediatric cardiac services are not available in all the cities. So it's very important that in my view, the first step in diagnosing these congenital heart diseases where in the clinical examination. Okay, first you should suspect based on your clinical findings, clinical signs, that this baby might be having a cardiac problem. Then only you can do the echoes. Okay, so the first step here is a good clinical suspicion. Like if you see a baby with poor perfusion and shock, not responding to your routine treatment like fluid bolus, inotropes, not responding, and feeble femoral pulses, then you should get an idea. This can be a coarctation, this can be a critical aortic stenosis, this can be a hypoplastic left heart. So you should have that clinical suspicion first before venturing. So clinical suspicion is very important. Okay, and if you have differential pulses, okay, good radial pulses, but poor femoral pulses, or differential cyanosis, 100% saturations in the upper limb, but 80% in the lower limb. Okay, and respiratory distress, not responding to treatment, persistent cyanosis. Okay, and if you hear a heart murmur, okay, or abnormal chest X-ray and ECG changes. Okay, these are all the things which will stimulate you to think towards any cardiac problem. So first step is always clinical examination. Okay. So as my colleague told about systematic segmental approach, what I do is I go sequentially. I don't go jump the boat. So I go sequentially. First see the SVC, IVC and establish their connection to the atria, and then atrioventricular connection. Then I review the ventricles and it's a ventricular septum. Then I go ventricular arterial connections, that is aorta and pulmonary artery, and see the walls. So you need to go systematically. Then you see the branch pulmonary arteries and descending aorta. So if you go systematically, you won't miss. Okay, like the follow a rhythm. Okay, then you don't miss it. So this is a classic. I'm not going to go in detail about this classification because most of you know. Congenital heart diseases are classified into acyanotic heart diseases where you got left to right shunts like AST, VST, and PDA. And other these critical obstructive lesions like aortic stenosis, coarctation of aorta and hypoplastic left heart, and pulmonary stenosis, that's on the right side. And cyanotic heart diseases like the common 5 Ts, tetralgia fallo, TGA, truncus arteriosus, TAPVD, and tricuspid atresia. So these 5 Ts. But the first heart problem, acyanotic heart diseases, usually they don't present in the neonatal period. Okay, so they present after 4 to 6 weeks because of the high pulmonary pressures in the early neonatal period. Okay, because as you all know, fetal circulation is different. All the fetuses will have high pulmonary pressures. When they deliver, the pulmonary pressures are high. There won't be much shunt. So the common age of presentation is 4 to 6 weeks of age. And the main role is to diagnose these these are classified as critical congenital heart disease, where the critical obstructive lesions and the cyanotic lesions. These things you need to diagnose early, okay, to give a good outcome. Okay. So there are some clues, even though you go systematically, there are some clues, okay, which I follow. Okay, these clues will help you in diagnosing, okay, a heart problem. Main thing is as the PFO. If you see a PFO with right to left flow, you should you should look for some right side obstructive lesions apart from pulmonary hypertension, like TAPVC, tricuspid atresia, and right heart obstruction. If you have right heart obstruction, you are bound to have right to left shunt across the PFO. So if you put a probe subcostal, if you see right to left shunt across the PFO, you should not leave. You should make sure you don't have any congenital heart diseases. Second is PDA, right to left flow. So if you have left heart obstruction, okay, if you have critical aortic stenosis or coarctation of aorta, the systemic circulation is supported by the PDA. So you will have right to left flow across the PDA. So if you see a right to left flow across the PDA, you should not assume it is a just pulmonary hypertension. Okay, you should need to see aortic wall clearly. You need to see descending aorta clearly. And if you are not happy with the views, don't say that there is no coarctation of aorta. I can't see the views, and get some help. Okay, so but very important. If you follow these principles, you won't miss a case. Okay. Then retrograde arch flow you see in hypoplastic left heart and aortic stenosis. And the most important thing I follow is, if you have a chamber and vessel asymmetry, for example, if you have a right heart dilatation, okay, then there is a problem with the left heart. So babies with critical aortic stenosis or coarctation of aorta, they will have prominent right heart. Okay, if you have prominent left heart with a small right heart, that means there is a problem with the right heart, critical pulmonary stenosis or something like that. Okay, chamber asymmetry is very important. You should not ignore. Our tendency is, if you see a big right heart, to label it as a pulmonary hypertension and to start the treatment. Okay, don't assume that. Pulmonary hypertension is a diagnosis of exclusion. Once you exclude all the heart problems that can cause right side dominance, then only we should label it as a pulmonary hypertension. Okay. So I will give you the videos. This is the baby with shock, circulatory collapse. And this is a 4-chamber or 5-chamber view. You need to shout the diagnosis, okay? Videos play out. Okay. Okay, so okay, what do you see? The first videos are not playing, but we'll see. What do you see in this echo? You need to shout whatever you are seeing. Yeah? So what view is it? So this is apical 4-chamber view. Yeah. This is left atrium. This is left ventricle. And this is, yeah, aorta. Please shout so that it will be more interactive. What are you seeing here? No, this is mitral regurgitation. This is mitral wall, yeah? And this is aortic wall. Can you see a turbulent flow across a aortic wall? This is aortic wall, yeah? This is 4th chamber. So left atrium, left ventricle, and this is 5th chamber, yeah? This is interventricular septum. Okay, this is intraatrial septum. So there is turbulent flow across the aortic wall. Okay, this is going to be aortic stenosis. Okay, I say it is critical aortic stenosis because if you see, the left heart function is not good. It's impaired. Because of the critical aortic stenosis, the function is impaired, the patient presented in shock. So like if you continue to give inotropes and all, it won't help much. Okay, you should have a clinical suspicion and do echo. Okay. So this is a bicuspid aortic wall. And I'll skip this because of lack of time. Okay, this is another case with neonate with shock. Okay, you are giving fluids, you are giving everything, but baby is not responding. Okay, and you can't feel the pulses. So you got the echo. So what are you seeing in this? Just to describe, what view is this? Yeah, apical. Yeah. So that's very good. So he says the right ventricle, right heart is dominant, and ventricular function is impaired. That's very good. Okay, then when you see this, you should have there is some problem with the left heart. Okay, so then in your mind you should say, oh, right heart is prominent. I need to make sure aortic wall is good. I need to make sure descending aorta is good. Okay, otherwise, if, without seeing them clearly, you should not complete. You should not write the report. Okay. So this is the aortic arch view. What are you seeing? Yeah, yeah. Okay. So this is coarctation of aorta. So this baby got severe coarctation of aorta. Okay. So in the antenatal period and early neonatal period, right heart is supporting the systemic circulation. Right heart is supporting the pulmonary circulation and the systemic circulation. That's why it got dilated. Okay. So you need to make sure you're not missing any coarctation of aorta. It is often missed because when your baby is crying and all, you will see up to here only. You don't see all the time good views. And you say aortic arch is good and you just document. Okay. But you need to see descending aorta. Okay. Behind the chest also. It's very important. So this is a Doppler across it. And you will see increasing velocity up to 4 meter per second and also diastolic tail. Okay, this diastolic forward flow is classic of coarctation of aorta. Okay, this is a well baby. You can see the upper limb saturation, well baby, upper limb saturation is 97% and lower limb saturation is 81%. Okay, so this is what is the clinical sign? Differential cyanosis. Okay, so what heart disease you suspect based on the clinical finding? Yeah, coarctation of aorta. Okay, so that's why I said clinical findings is very important. Okay, so I think there is some problem. I can't play all the videos. This is a short axis view. Okay, in this view, you will see a small aorta, smallish aorta, and prominent pulmonary artery. Here, this is what view is this? Yeah. So short axis view with the pulmonary artery bifurcating. Okay, and here there is a clue. Okay, now everything is playing good. So here there is a clue, and when you are seeing a short axis view, if you see turbulent flow here, okay, that means there is coarctation of aorta. So these are all the clue not described in any textbooks. Okay, these are all my teachers told me, like how not to miss coarctation of aorta. When you are seeing a short axis view, if you see turbulent flow below that, left LPA, turbulent flow, that gives a clue that there is a coarctation of aorta. Okay, so you should get these clues. Okay, and if you see the 5-chamber view, okay, so this is pulmonary artery, which is prominent. This is aorta. Aorta is smaller than the pulmonary artery. Here, right heart is dominant, left heart is smallish. Okay, so left side structures are smallish. That should give you a clue that there is some problem in the left heart. And this turbulent flow below the left LPA should give you another clue that it's a coarctation of aorta. Yeah, yeah. Okay, so this is a echo. You can see the aorta arch view, ascending aorta. Can you see the transverse arch getting smaller? And here this is a coarctation of aorta developing. Yeah, it's not very tight. Yeah, and if you can see the ductal flow is bidirectional, and there is right to left flow and left to right flow. That means the duct is supplying the descending aorta. That's why we are getting the low saturations. Okay, so if you diagnose here, that's good. If you don't diagnose this and send the baby home, the PDA closes and baby collapses and dies. Okay, baby is dependent on the PDA. So it's very important. Okay, so here you should get, the baby is very well. You should get the suspicion with the differential saturations. It's very important. Okay, so this is a severe form of anyone wants to comment? We'll move quickly because lack of time. Anyone wants to comment on this echoes? Okay, that's good. Okay, these are the three views. Concentrate on this first one. Okay, this is aortic arch view. Okay, second with the color, and third is the ductal flow. Okay, based on this, what are your comments? Can you describe what you are seeing here? So concentrate on here. Yeah, this is bidirectional flow. So concentration these two. Okay, this is aortic arch, and this is left carotid artery. Yeah, left carotid artery, and this is left subclavian artery. Yeah, and you can't see any connection. So this is severe form of coarctation of aorta, that is called interrupted aortic arch. Okay, so if you can't see the continuous arch, you need to think about interrupted aortic arch, and this baby will have upper limb saturations high, lower limb saturations low. Okay, always saturations, upper limb and lower limb saturations will help you a lot in all the, in units. Okay, so you need to concentrate on that. Okay, this is cyanotic baby. Okay, we'll move on to cyanotic baby. Okay, so describe me what you are seeing in the first one. So this is the subcostal view. This is left atrium. This is right atrium. Okay. No. Just concentrate. This is left atrium. What the structures you are seeing is left atrium, right atrium, and interatrial septum. Okay. This is SVC. So what is this? PFO. So what type of flow is that? Right to left. So that means there is a abnormality here. Okay. Right to left flow across the PFO means there is some problem. Okay. So, and see the next. Okay, this one you can see 4-chamber view. Okay, and this is a ventricular septum. Yeah, VST with the right to left. That means right heart pressure is very high. Okay, and this is short axis view. You can see RVOT, main pulmonary artery. Okay, and this is pulmonary wall. So can you comment on that wall? Yeah, turbulence flow in the pulmonary wall, and you can see pulmonary valve is not opening. Yeah, that means it is pulmonary stenosis. Or no, there is forward flow now, you can't call atresia. If there is no forward flow, then atresia is correct. So it is critical pulmonary stenosis because the baby is cyanotic with right to left shunt. Okay, so if you have right side obstructive lesions, you will have right to left shunt across the PFO and right to left shunt across the VST also, and right side dominant. Okay, the velocity is 4.5 meter per second. Okay, so those are the obstructive lesions. So we covered left side obstructive lesions and right side obstructive lesions in brief. Okay, you know the clues how to diagnose them. Okay, so now we'll move on to the other category of cyanotic heart diseases. So this is I feel this is one of the common presentation where even at a very in my last 10 years, I've seen many experienced pediatric cardiologists missing the diagnosis. Okay, so just listen carefully to this. So, and this is a common scenario you all neonatologists come across in a day-to-day life. Okay, so neonate with severe respiratory distress. Okay, and you did a chest X-ray. Chest X-ray is like this. Okay, you are very familiar with this. Yeah, with this. So then you ventilate nitric oxide, high frequency ventilation. Baby will be struggling a lot. Okay, not responding to your treatment. If it is a meconium or something like that, they should show some response as you are giving. But if they are not responding and deteriorating, then you should be thinking, okay, so there might be something else apart from the common etiology. Okay, then you think about the cardiac. Okay, so that's how your thought process goes. Okay, and this is the as Dr. Navid said, this is the subcostal view, the situs view. Okay, you are seeing the diaphragm, vertebrae. This is aorta. What I am pointing is aorta. Okay, this is the IVC. Okay, you want to comment anything here? Any abnormal? Is this one? Yeah, yeah. So the clue here is, yeah, so you are trying to say something, diagnosis. That is TAPC. What type of TAPC? Intracardiac TAPC. So here the clue, okay, even though you don't see the pulmonary veins, you don't see anything, the clue is there is a prominent venous structure in the liver. Apart from aorta and IVC, there is some prominent venous structure in the liver. That should give you a clue that this can be a infracardiac obstructive TAPVD if you match it with the chest X-ray findings and clinical features. Okay, so you should get all these clues. When you are seeing the situs view, just don't jump to the apical views and all. When you are seeing the situs view, you should think, before you do the scan, you should have, this can be a TAPVD, this can be an infracardiac TAPVD. So I am putting the probe. I might be seeing a extra venous channel in the liver. Okay, and you put the color and see. Okay, that should be your thought process when you are doing. And here, I will show you, how difficult it is to diagnose infracardiac TAPD. So here, this is the four chamber view. What are you seeing in the four chamber view? Yeah, dilated RARV. Okay, this is another condition where you see dilated RARV, very dilated. Okay, and here what you are seeing? What is that blue flow? PFO right to left shunt. Okay. Yeah, yeah. So when you are seeing that I will come to that point also. This is a common mistake even the pediatric cardiologists and neonatologists do. When you see a four-chamber view with a dilated RA and RV, we assume that it's a severe PAH and start the PAH treatment. In my view, with all the experience I got and with all the mistakes I did in my career, with all the diagnosis I missed in my career and my senior consultant missed it, I will say that pulmonary hypertension should be a diagnosis of exclusion. You should exclude a whole lot of diagnosis. Then only once you are confident that I excluded all the conditions, then only you should say it is pulmonary hypertension. If you are in doubt, you should get help. Nowadays, it's very easy to get the help. You make a record and send it to anybody you know, Dr. Sahani or me or anybody. Just send it and can you say in the WhatsApp you can get the diagnosis in 2-3 minutes. Okay, but you need to be absolutely sure. Okay, and this video will demonstrate how we miss. Okay, this is a common mistake we did when we are a trainee and we did when we saw when our senior consultant missing. So you have seen a right to left flow across a PFO. Okay, and what is this red flow? What is this red flow? Pulmonary venous flow. Huh? So this is the common mistakes we did, okay, as a trainee. This is the common mistakes even the senior cardiologist. So what happens in TAPVD, okay, this diagnosis is clear, infracardiac TAPVD will go through. But the mistakes I did and we did is, usually because the right side heart pressure is very high, you see a right to left shunt across the PFO, it hits the roof of the left atrium. It hits the roof of the left atrium and comes down. And when we do the scan, we all assume there is a pulmonary flow because you are seeing the red flow coming from the roof. We see, so you don't get misguided by this. This is a common way. So, even we use it, oh, I have seen the pulmonary venous flow, how can it be TAPVD? Then when we review it retrospectively, all the time, most of the times, PFO flow goes and hits the roof of the left atrium and comes down. The moment you see a red flow coming from the roof, you assume it as a pulmonary venous flow and say, ruled out TAPVD. And that's a common mistakes we do. Okay, so from now onwards, if you are doing a scan for a clinical condition like that, don't get misguided by that. You need to see pulmonary veins coming individually to the left atrium. Then only you can say diagnosis is excluded. If you are not seeing it, you can see TAPVD can't be ruled out. Medical legally, we should be very accurate now. Okay, don't get fooled by these mistakes. Okay, these they won't describe. These are all experiences. People make mistakes and we pass it on. So here the same. If you see there is a pulmonary venous flow, we can say it is not TAPVD, but this is actually TAPVD. I will show. Okay. So, and if you tilt it posteriorly, you will see what are you seeing here? This is another clue. Okay. First clue, you got that point of PFO flow hitting and misleading you. Second clue is here. What are you seeing here? Huh? Yeah. Common chamber where? Here? Yeah, yeah, yeah. Okay. So this is the confluence. Where is the left atrium? Compressed. Okay. That's good. So this is the left atrium. Okay. So yeah. So another point is, don't, with one view, don't make a decision. You need to sweep posteriorly, anteriorly, and many times the confluence is not as prominent as here. It will be very thin. And the lesson, my teacher told me, still I remember it every time, is if you see any chamber or structure behind the left atrium, okay, that must be TAPVD. Okay, you should not see. The structure you see behind the left atrium is aorta, nice arterial aorta, round structure. Okay, but if you are seeing anything between the aorta, so here I will show you, this is descending aorta, round pulsatile structure, and this is left atrium. This is confluence. You should not see anything behind the left atrium. Behind the left atrium, descending aorta, that's it. If you see any extra structure behind the left atrium, you must say it is the TAPVD, and you should establish the pulmonary veins going into that and all. Okay, there is another rare condition where you can see like absent pulmonary valve syndrome. That's a pulmonary artery also you see sometimes, but because it is so rare, don't worry about that. But if you see any chamber behind it, then assume it is TAPVD and look into the pulmonary veins draining into it. Okay, this is the second lesson. One PFO flow and any chamber behind the left atrium you need to. Okay, these are all the clues. And if you track that confluence, in the liver, you can see this descending vein. No, no, no. This is liver. Oh, yeah. Okay. So this is liver, and this is the that confluence going into the IVC. Okay, you can see dilated IVC entering into the right atrium. Okay, if you see dilated IVC means there is something else going into that. If you see dilated SVC, there is something going into the SVC. Okay, so these chambers, when you are seeing the situs view and all, you need to think about is IVC is normal size. If you see a confluence, normal size IVC but big SVC, then you should think it is supracardiac TAPVD. Okay, this is a infracardiac TAPVD. You can see the vein coming down and opening into the IVC at the end. So this is another echo picture. Okay, so this is another echo. Can you see the left atrium and what is this? Confluence. And what is this? Descending aorta. So here you see a small structure. Sometimes it is so thin that you won't describe. Like it is so thin. So you need to be very clear getting the views. Okay, baby with low saturations and mild distress. So what are you seeing here? Just concentrate, don't concentrate on the diagnosis. Here, so what are you seeing? Just describe 4-chamber view. Yeah, dilated right side. Then you need to think about TAPVD and coarctation of aorta, left side obstructions. Okay. So then what are you seeing? What is this? What is this chamber? No, this is LA. And what is behind it? Confluence. And behind it is a descending aorta. Okay. And that confluence, if you follow that confluence flow is coming down and entering into the right atrium. So that's a coronary sinus TAPVD. That's where the coronary sinus is. Okay. So if you see this structure of the heart, these are the pulmonary veins, and the small vein below it, between left atrium and left ventricle, posteriorly is a coronary sinus, and it opens into the right atrium. If you have coronary sinus TAPVD, these 4 pulmonary veins confluence and enter into this coronary sinus and gives rise to coronary sinus TAPVD. No, no, no.
Just I need a funds to he told only one thing. He never asked another. Just even the second he never asked. He told Tamil means brother, elder brother. I am there, go ahead.
Thank you. Yeah. Okay. So this is another case of a baby with low saturations and mild distress. Okay, you can see prominent right heart again. Then you need to think about TAPVD, and here you can see a confluence just below the, just behind the left atrium. Okay, and you follow it. What are you seeing here? Okay, can you see the confluence? Yeah, with all the four pulmonary veins. This is the crab view. Four pulmonary veins going into the confluence and going up ascending vein and innominate vein into the SVC. Okay, it is supracardiac TAPVD. Okay, here you can see the CT scan picture with this is a ascending vein, innominate vein, and IVs, SVC. Okay, that's a supracardiac TAPVD. That's how you get the figure of 8 experience. Okay, so the lesson here is PFO with right to left shunt should give you a clue. Dilated IVC or SVC or coronary sinus should give you a clue about how the pulmonary, where the pulmonary veins are going. And if you see any chamber, okay, behind the left atrium, you should suspect a TAPVD. And these chambers are, this extra chamber is not always visible. You need to look for it. Okay, and don't get fooled by the flow coming from the roof of left atrium. Okay, that is a common mistake. Okay, this is another case. Okay, so the very rare case. I will skip on to this thing. So this is a case with dilated RA and RV. So there are other conditions where you get dilated RA and RV. Okay, and so far we covered left side obstructive lesions and also TAPVD. And third in the rare is if you have any AV malformations like brain and liver. Okay, brain is vein of Galen malformation, liver is liver AV malformation. Okay. So when you see the right dilated right side, I simply scan the brain and liver also to rule out. Then only I will say it is PPHN. Okay. First coarctation of aorta, or second TAPVD, third any brain AV malformation, liver AV malformation, and then diagnose it as a PPHN. So this is a case of vein of Galen malformation. You can see the brain showing that is a vein of Galen malformation. Okay, most of you know how to diagnose. So this is a vein of Galen malformation in the middle. Okay, because of lack of time, I am skipping it. And this is a case with the liver AV malformation. So this is subcostal view where we see the liver, and if you put a color flow, you will see multiple vascular structures, and that should give you a clue that it is a brain liver AV malformation. If you see a dilated SVC without TAPVD, then you should suspect vein of Galen. Okay, if you see dilated IVC, okay, then you should suspect hepatic AV malformation. Okay. So in my view, sick neonate with right heart dilatation, first you need to rule out TAPVD, coarctation of aorta, AV malformation. After excluding all these only, then you should label it as severe PAH. Okay, that is the lesson for all of you. Okay. So, okay, this is a cyanotic baby. Okay, what are you seeing in this view? What structures you are seeing here? What structures you are seeing there? What is this? Huh? This is a no. This is apical view. This is, what is this valve? Okay, this is left atrium, left ventricle, and it should be aorta. But what you are seeing here, there is a great vessel coming and bifurcating. Yeah. Okay. So don't assume that every vessel coming from the left ventricle is aorta. How to differentiate aorta and pulmonary artery? Yes, pulmonary artery bifurcates. Ascending aorta just goes up and gives head and neck vessels. Okay, like an arch. Okay. So here you can see pulmonary artery, like you can see a great vessel coming from left ventricle, which is bifurcating. That must be pulmonary artery. And you can see from the, if I sweep anteriorly, you are seeing a RV giving rise to a great vessel which is not bifurcating. That is aorta. Okay. So right ventricle is giving aorta and left ventricle is giving pulmonary artery. What is the diagnosis? TGA. Another clue is what we said is great vessels usually in normal position they crisscross. Here they are parallel. So then that is another clue. Okay. So this is the same baby. What view is this? What view is this? Long axis view. Okay. Here another clue. This is no, this one, left atrium. This is this structure, left ventricle. Yeah, can you see the branches? Here one and here one. Another clue here is, in a normal baby, when you are doing the long axis view, if it is aorta, usually aorta goes anteriorly. Okay. In normal, aortic wall, if it is aortic wall, it should go like this, in this direction. Yeah? But here you see a great vessel which is not going in this direction. It is going posteriorly and bifurcating. Okay? And that should give a clue that it can be a TGA. Okay? And second clue here is, you see a pulmonary artery going posteriorly and bifurcating, and here you can see a aorta coming out from the right ventricle. So that's a clue that it is a TGA. Parallel vessels, double barrel gun shape, Okay, all these descriptions are there. But if you see a parallel vessel in long axis also, it's a TGA. Okay, if you follow it up, you can see like this. Yeah, pulmonary artery and aorta parallel to each other. And in the short axis view, yeah, in the short axis view, you will see the pulmonary artery which is posterior, which is dividing into right pulmonary and left pulmonary. Aorta is anterior. Okay, but normal baby, aorta is posterior, pulmonary artery is the anterior most structure in the heart. Okay, so these are all the clues that shows. And most important is clinical suspicion. A cyanotic baby very well not in distress, that should give a clue we are dealing with a cyanotic heart disease. Then so you should have that 5 T's in a differential diagnosis. Clinical suspicion, 5 T's in the brain. Then you do the scan. Don't do it blindly. First clinical findings, make a map, and then put the probe. Then it is easy to make a diagnosis. Okay? You're asking something? Or, okay? So this is a TGA. This is normal crisscrossing in a normal baby. Here parallel vessels, pulmonary artery coming from left ventricle, aorta coming from the right ventricle. Okay, same views. So these are other echoes. I will skip it. There is another cyanotic baby. Okay, what are you seeing? Can you describe? Okay, it's not, videos are not playing. Oh, good. Okay, so, some problem, videos are not playing, but I will tell you. This is, 5-chamber view, left atrium, left ventricle, and aorta. Sir? Some selective videos are not playing. Okay, we'll just leave it. Okay. Okay. Oh, now it is playing. Yeah. So can you see? Okay. So this is left ventricle, right ventricle, and aorta. Okay. And this is, sorry, I'm sorry, left ventricle, right ventricle, ventricular septum, and here is the aorta, and this is a VST. Okay. So you can see a perimembranous VST, and also you are seeing a aorta overriding. Okay. And aorta is getting the flow from both right ventricle and left ventricle. Okay, to the aorta. So left ventricle, right ventricle, interventricular septum, and here is a VSD. From here to here is the VSD, and aorta is overriding the. If you see this picture, you should have one diagnosis in your mind. Okay, then you go to the next. In the long axis view, you can see the ventricular septum, left ventricle, right ventricle, and this is aorta overriding. Okay, overriding the VSD. Okay, so that should give a clue that it can be a tetralogy of Fallot. And then you do the short axis view. You can see, so usually you will have a circular aorta, but here because of the VSD, you can see a VSD. And this outlet septum is deviated antero superiorly, causing severe RVOT obstruction. So this is a RVOT obstruction. Okay, and if you see a continuous wave, you are seeing a 4 meter per second. So pulmonary stenosis. Okay, so this is a tetralogy of Fallot. Okay, VST overriding of aorta, pulmonary stenosis. That should be with the clinical findings, tetralogy of Fallot. You will see ejection systolic murmur. It should support your clinical findings also. Okay, so this is another cyanotic baby, well baby, but low saturations. And just to describe what you are seeing. Just to describe what you are seeing. So what view is this? It's a apical. What 4-chamber view? Yeah. Okay. So what are you seeing? Just to describe. What is this? RA. Good. What is this? What is this? Mitral valve. What is this? Yeah. Left ventricle. What is this? Right ventricle. What should be between right atrium and right ventricle? Can you see tricuspid wall? So you can't see any tricuspid wall. What are you seeing? You see a ridge. Okay, without blood. So what is this diagnosis? Tricuspid atresia. So if you don't see tricuspid wall and a ridge across it without any flow, that should give a tricuspid atresia. Usually, most of the times, tricuspid atresia associated with ASD, VSD, sometimes TGA, tetralogy. The whole lot of combination can happen with the tricuspid atresia. But this four-chamber view should give you a clue that it is a tricuspid atresia. Always go systematically. That's what I am saying. Veins, atria, atrioventricular valves, mitral valve and tricuspid valve, ventricles, great arteries and all. Then you don't miss. Okay, so I'll skip this. We are coming to the end. And the final T is truncus arteriosus. In the embryonic life, we have two great vessels, aorta and pulmonary artery, but in embryonic life, they come from single vessel called truncus arteriosus. Single vessel comes and it goes up as a aorta, and from here, from the ascending aorta, you get a main pulmonary artery dividing into two. Okay, that is truncus arteriosus. That's embryonic life. So failure of septation will lead to persistent of truncus arteriosus. Okay. So this is a example of truncus arteriosus. Unfortunately, it's not playing. You can see this is a trunk. Okay, going up. Oh, somebody. Huh? Ah. Cannot play. Maybe there is some problem. Huh? Okay, he's doing. It says cannot play. So what you are seeing here is this is aorta. This is a truncus going up as an aorta, but you can see from the side there is a pulmonary arteries coming, bifurcating. So this complete is the truncus arteriosus going up as a aorta. From the side you are getting two branch pulmonary arteries. This is left pulmonary artery and right pulmonary artery. So as a definition, aorta should not have any branches except small coronary arteries. So these are all the clues. Aorta doesn't have a branch. The only branches it gets is coronary arteries. If you see any branches apart from that, that can be truncus arteriosus. If ascending aorta is giving prominent branches, you should say it is truncus arteriosus. Okay, this is we are coming to the last slide. So this heart, can somebody comment? Okay, left atrium, left ventricle, right ventricle. Okay, left ventricle is very small. That means it is a hypoplastic left heart syndrome. So you should always go systematically. And ascending aorta is very small, like 2 millimeters. So hypoplastic left heart is usually associated with aortic problems. Okay. And this is hypoplastic right heart. If you see in a pulmonary atresia, intact ventricular septum or critical PS, the right ventricle is very small. And they are very, obvious. When you see a four-chamber view, one chamber is very small, one chamber is dominant, then you should suspect. So these are, so in conclusion, so I will give, lack of time. These are the most important points. First step is always clinical findings, clinical assessment, and suspicion is the most important thing than doing echo. Okay, first most important is clinical suspicion. The second one is when you are starting an echo, before starting, this is the lesson I learned. Before starting the echo, you should have a differential diagnosis in the brain before starting the echo, based on the clinical findings. Otherwise, don't start. You assess the clinical findings, have some differential diagnosis in the brain, then put the probe. Okay, your eyes won't see what your brain doesn't know, so you should have some idea what you are going to see, then put the probe and investigate for that diagnosis. Okay, systematic segmental analysis is very important. And the most important is while going through the presentation, I told you about some clues, how to diagnose. And stick to remember those clues. Always consider those clues while you are doing. In doubt, don't just make a diagnosis. If you are in doubt, get help. Now there is a technology. WhatsApp is there. You can record a clip and send it to anybody. and everybody will be happy to help you in getting a diagnosis. And I do it every day with all my colleagues, neonatologists. Okay, and most of the times, 99% of the time, we get the diagnosis with WhatsApp clip or some sort of suspicion. Okay, thank you very much for listening. Thank you.
This is very important, but just don't think that you have attended a advanced workshop and you go and whenever you feel a doubt, always take the help of pediatric cardiologist. That is very important because I still know. Once I was as told, I was doing an echo. I told it's. I was in a hurry. I just sweep. I did. It's no normal. My colleague he told no sir. This is TGA. Clinically this is TGA. Please see it again. And when I stood there, saw it was a TGA. So the clinical diagnosis, your clinical diagnosis cannot be wrong. Your echo can be wrong. So that is very important. So next speaker is Dr. Ankit, and he's not there because of some issues. I will take that shock thing. I will take the lecture instead of him. Thank you very much.
Hello, good afternoon, everyone. So there will be no coffee break because we are running late. You people can make yourself comfortable. Can go and have coffee and come back. Thank you.
What was the afterload, isn't it? Okay, fine. Okay. Why it is not playing? Yeah, play this, please. Just okay. So it has not been playing. So let's go for the. So whenever we talk about the cardiac outputs, fine. So these are the few things we need to look at. Left ventricle output, SVC flow, RVO, and what is the fluid status by assessing the IVC. So these views you have clearly, it's just a revision. Okay, these are the various windows you need to. So, so what is this view? Apical 5-chamber view, isn't it? And this is where you will keep the probe. Okay, and this is how you will see it. It is upright, not inverted. It's anatomically corrected upright. So this is your aorta. So when you calculate the Dopplers in aorta, you need to keep the pulse wave Doppler here just above the aortic wall here. And then you will calculate the VTI in that. This is what is the VTI. Here you will calculate. So VTI is velocity time integral. And this is the formula to calculate your LVO. Pi r square, that r is the radius of the aorta, heart rate into the VTI which you have just calculated divided by weight in kgs. And this is how, when you get that, we will show you on the workstations. This is when you get this Doppler flow of the aorta, this is how you calculate the VTI in that. Okay. And then this view is basically to calculate the radius of the aorta. So this is parasternal long axis view. This is where you will keep the probe as it is shown in this video. And this is how you will see it. And now you can appreciate this point, this probe orientation marker is up, not down. So this is a Plaque's view, and this is where you will calculate your aortic diameter from this point to this point at the level of aortic valve when the valves are open like this. So this is how you will calculate your diameter, and the half will be the radius. isn't it? So this is your formula. Okay, your aortic diameter means if your aortic diameter divided by 2, if you do it the whole square, this is how it will come. Or you can make it half and then pi r square into heart rate into aortic VTI divided by your weight in kgs. It is also been known as the cardiac index. Okay, why we need to divide by the weight? Because suppose if I get some figure for 1 kg baby and get some figure for 3 kg baby, it will be different for different babies with different weight. So that's why to divide it with the weight is very important. Okay, now the question for you, you need to do this exercise. This is 28 weeker, 980 grams, 0.98 kg baby, heart rate of 168, aortic diameter of 0.62 centimeters, aortic VTI calculated is 10 and pi value is 3.142. What is the LV index or cardiac index for this baby? Like if you put these values in the machine can calculate, but if not, then you have to manually calculate these values, see the values and manually calculate by yourself. Anyone? 517, yes, it is 517. Okay, this is how it is being calculated. Okay, so what is the significance of this? You have a preterm baby, 28 weeker, 980 grams with left ventricle output or left LV index is 517. And the normal value is, actually it is from what we take in our studies, what we have taken is 125 to 310 ml per kg per minute. So it is low or high? High. Then what can be the issue? PDA, HSPDA, hemodynamic significant PDA, because the volume overload is, like if I don't see even the PDA, if I just calculate my LVO and see in a apical 4 chamber that LA-LV is dilated, this is my left ventricle output index. So it is volume overloaded. The most common reason for preterm baby with 900 gram baby will be my PDA. Okay, so you should be well aware of this. Yeah, so that is here is the point. So this is a one technical point which I didn't bring out because I thought the PDA will people will, but this is very important. So what we say is if your ASD or PFO size is more than 4 millimeters, then there will be shunting from LA to RA. Okay, so the amount of LVO you will get will be under. Okay, so it will be under assessed. So that's why if your PF4 ASD size is less than 4 millimeters, then it is reliable. But if your size is more than, because your LV will be bloated like this if the volume overload is too much. So what we say is if your size of ASD or PFO is more than 4 millimeters, 25% of the blood from LA, instead of coming to LV, it goes to RA. So then your LVO, what you have calculated, will be under assessed. Actual what should have been, it is under by more than 24%. So it has to be smaller. Your PFO or ASD size should be smaller than 4 millimeters. So there is very good point which sir has brought out. So this is one thing we need to keep in mind. It's a large VSD, very large ASD. Yeah, but the thing is, what happens in, what is the difference between in pediatric age group or bigger babies and newborn is, your right-sided pressures are physiologically higher as compared to the bigger babies. So the effective shunting of ASD, even your size is bigger, is not that much in newborn babies because your physiological high pulmonary pressures are resisting that. So that is one way. That's why your, even with large ASD, your newborns does not present very early because of that. Yeah. So they present late. So many times they happen your ASD is there, and if it's a large ASD, then they present in pediatric age group with bigger RA and RV because of volume overload of RA RV. But it happens later. Am I right? Because I don't have much of the experience for pediatric age group. Yeah. With the failure, yeah. ASD, yeah. So, so now the question is, this one thing is clear with everyone? Now the question is, if I can calculate my LVO, Okay, then why I am bothered about calculating my SVC or RVO? RVO, I still, if it is shock or it is shock because of PPHN, I know I need to know the outputs of my right ventricle. Then why I am concerned about my left ventricle outputs if I am able to? Because the reason is, if you have a big shunts at atrial level or at a ductal level, okay, then they are faulty. They are not actual representation what the body is getting. Why? You can see with this diagram. Just concentrate on this diagram. It is very important. See, this is your LV, this is your LA, this is your RV, this is your RA. Fine. So now see, this is your lungs, this is your body. Fine. From body, this is what? IVC and SVC. This is coming into your RA, going to RV, and then it's going to the lungs. Clear? This is your lungs. This is your pulmonary veins. From pulmonary veins, the blood is coming your LA, going to LV, and then going to the body. Fine? If you think 100 ml of blood has come into RV, okay, and 400 will go on into LA. Okay, why it is happening is, there is a PDA, this connection is here. Fine? What we are doing is, when I measure my LVO, what I do is, I keep my probe here and calculate my VTI. Clear? The PDA is after that place where I am measuring that flow of what we call is LVOT, left ventricle outflow tract. Okay, the PDA is ahead of it. So the blood has not shunted yet. So whatever VTI I am measuring is before that ductal shunt here, just when the aorta is started from LV. Okay. So if I measure there, what I will get is that the blood which is going out of LV is 400 ml. But then after that, 300 ml has shunted from PDA and has joined in the pulmonary artery, okay, and gone into the lungs. So instead of 100 ml going into the lungs, it is 400 ml which is going. And instead of 400 ml going into the body, only the 100 ml is going. But what you have measured is 400 ml. Now you got my point? Why there is a fault issue with this? So that is an issue. So that's why, suppose if do it at SVC level, okay, IVC or SVC level, it will show 400, isn't it? See, this 400 is coming from the lungs. Oh, sorry. Yeah, gone to the this thing. This thing is gone into the lungs. Okay, 100 plus 300, and then come back. And when you measure through SVC, it will be 400. So what they thought, it will be actual representation what the body is getting. It is not exactly the numbers like this. This is just to make you simplify, make the thing simplify for you. Means what actually the body is, pardon? 100 from SVC, yeah, SVC. But so yeah, sorry, it will be 100 from SVC because that what the actual the body is getting. You got my point? Because the 300 when it gone to the PDA, gone into the lungs, the body has received 100. SVC will measure only the from the upper part of the body, but in newborns we think it is 70% of the total. So actually it will be around 70, 75, but it will be close representation what the body is getting instead what you are getting through the LVO. You got my point or not? So that's why people doubted that if you have a hemodynamic significant PDA, you should not be relying on your LVO, left ventricular outflow. Clear? Yes. So I will be coming there also, because then we will get a very good VTI. But then the issue comes when we try to measure the size of the pulmonary artery. So why there is an issue with I will be coming to that also. Why there is an issue with measuring the size of the pulmonary artery. So now I've come into, which is this view? Views you have done, a kind of revision. What is this view? Subcostal cross-sectional view, isn't it? So again, the other thing which you will be seeing is the probe orientation marker is down here. This is what we have been taught in neonatal cardiology that, make the thing simplified. Near to the probe, you have RA near to the probe, just to make a anatomical, orientation. So this is your RA, this is your LA. So your SVC will flow into this like here. And then you can measure the VTI of SVC in this flow. Okay. So it will be something like this. Can you see this? The subcostal atrial view. Okay, the pointer is pointing at 3 o'clock position. And with pulse wave Doppler, as the SVC is entering your RA, you can measure just at the junction, you can measure the VTI for the same. The basic formula remains the same. Pi r square into VTI into heart rate divided by the weight of the baby in kg. That R will change. If it is LVO, the R will be of iota. If it is SVC, the R will be of SVC. If it is RVO, the R will be of pulmonary artery, isn't it? That thing only changes. Okay? And there are different views to calculate that. So this is your SVC flow. You are measuring your VTI in this. Fine. Now, as I told, there are two basic principles of ultrasonography. One, whenever you are trying to measure the Dopplers of any vessel, the flow of that Doppler, of the flow in that vessel should be parallel to your ultrasound beams which are going through your probe. Okay. Now you can see the probe is down here like this. The flow is flowing parallel to it. So that if you want to do the Dopplers of any flow, the beam has to be parallel to that. And when you want to calculate, measure the size of any particular part of the heart, your ultrasound beam should be perpendicular to it. Because of because we have skipped that basic ultrasonographic lesson in this, because this is supposed to be advanced, so you know this. So because this is as per the resolution, so it all depends on your axial resolution. So for your axial resolution to be the best, your beam should be perpendicular to the structure for whom you're trying to calculate the size. So that is a problem with the pulmonary artery, because there is no view in which your pulmonary artery is totally perpendicular to the beams of the. So that's why whenever you're trying, when the people they did it with CT scan and MRI, and they did it with echo, there is always a difference in the size of pulmonary artery. So that's why your RVO does not becomes reliable. So that is a big issue with the RVO calculation. So in this SVC, now you have calculated this VTI of SVC in this view. Fine. This is how you do it. And this is from where this thing is coming. SVC. And this is how you will see now you can see the shape of the wave of left ventricle output, aorta, was different from this, isn't it? But we have read in theory, there are 4 waves in SVC, isn't it? A, S wave, D wave, and the A wave, which is reverse wave. Why this happens? Because SVC is a vessel which varies with your respiration, isn't it? The size increase and decrease with your respiration. Okay, when you get negative intrathoracic pressure, it dips down, it goes in negative. But for the practical purposes, ideally what we have to do is, we have to calculate all the positive VTI, the area under the graph above, and minus the one which is down there. But it is so tiny that we practically don't take it into consideration. So we just calculate the VTI of those waves above in one cardiac cycle, and we take that VTI. Clear? Clear? Great. Then next thing comes, now I want to calculate the diameter of SVC. So that is a kind of high parasternal view. It is a kind of modified short axis view. So your pointer will be just above the nipple line towards the left side of the sternum. Pointer is facing at the 12 o'clock position here. And then you will be sweeping it towards your right side. Sweep towards the right side. Okay? This is what this picture is showing, and this video will show. This is how the lights are there. This is how you will see. This is your SVC. This one. Okay? Then you have to do the M mode in this, because this is a variable. This is how it will look like. Okay, here your M mode line will come. M mode is motion mode. Clear? and this is how it will see. So what you have to do is, you have to calculate the minimum size and maximum size and take an average of it. This is very important. So you have to take the average diameter of SVC, and then you take the radius out of it. Clear? And again, the formula remains the same. Pi r square into heart rate into VTI divided by the weight of the baby. And the normal value, the normal range of SVC outflow is 41 to 160 ml per kg per minute. Okay, as you can see, because it has to be 2/3 of your body output. Because SVC flow is basically mainly from brain and neck and head. Clear? But as I was talking about, there are pitfalls in this. What are those pitfalls? One, a lot of series of publication is there, but there are no, if you are doing SVC flow and I am doing SVC flow, there is a variation. And mainly where the variation comes when we calculate the size. Because when we do studies in sonography or in echo and all those, we talk about variation, okay, variability. The intra-operator means if I am doing the same value for 5 times, there will be a variability each time, but that intra-operator, same person doing the same reading for 5 times, that variability should not be more than 15%. And there is inter-operator variability. If you are doing that measurement, I am doing that measurement, that variability should not be more than, some papers say 25%, some papers say 30%. It should not be more than that. But when people try to extrapolate those studies, there was a lot of variability in that. So when you are doing that measurements, it was 50% variable from my measurements. So it was not reproducible as it was being done by someone. So that's why it is not reliable. That inter-operator and intra-operator variability was very high in this. So that was the main reason for this. You got my point? You understood? Great. So people try to do it with MRI, but again the thing is, there is no single parameter in neonatal hemodynamics which will give you the answer. You have to do everything. So when I get a baby in shock, I calculate LVO, I do SVC, both, just whether they are correlating or not. That is very important. Okay? This is what we have just discussed. Okay? So now you are clear about LVO, you are clear about SVC. We have to calculate that parameter is not reliable. So it has to be combined with each other. Then comes this RVO, okay? Again, I've told you the basic. So this is a parastern long axis view, and there are 2 sweeps in parastern long axis view. One is sweeping up. So sweeping up this is what is being shown here. Okay, my hand is just sweeping up. See there, isn't it? So that is your pulmonary artery sweep. So as you can see, that aorta which was there, it has gone, and perpendicularly you get this pulmonary artery. So this in fact rules out one anomaly also. This sweep rules out one anomaly. What is that anomaly? TGA. So that rules out your T. They are both perpendicular to each other. Sir also showed that double barrel gun view. What we say is TGA. Okay. So that is one thing. So this is how you can do the Dopplers in this. But whenever we do the measurements of pulmonary artery, we do it in this view. And as you can see, structure is vertical. My ultrasound beams are vertical. So they are almost parallel to each other. They are not perpendicular. There is not even a single view in cardiology in which we can have a pulmonary artery perpendicular to your ultrasonic beams. So that's why the calculation of the pulmonary artery Dopplers is not reliable. So this is for aorta. I will miss this. This is again, you can do it in apical 4-chamber view. Okay. If you sweep up, you get apical. Which view? After 4-chamber, if you sweep up, what view you get? 5-chamber. So then if you sweep further anteriorly up, as it is done in this video, this is what you will get. This aorta is gone, and then you instead, perpendicularly, you are getting another artery there. So that is your pulmonary artery. this is your pulmonary artery view. This is a Doppler. You calculate that again. Okay. But one thing is there. If you cannot rely on the diameter of pulmonary artery, one thing you can do, this will give you a kind of, uh, just an eye overall view. So what we do is, Dopplers you can do very well for pulmonary artery. When you do the Dopplers of pulmonary artery, and if your VTI of the pulmonary artery is less than 4, okay, that shows is a low cardiac output. If your VTI is more than 4, it shows your outputs are okay. So this is one very quick parameter. Now, if I am having a baby with PPHN, okay, there are other things in advance. The one lecture is there, the TAPSI and all that stuff is there. We'll talk about that. But if I want to quickly see whether outputs from the RV right ventricle are going okay or not, what I do, I quickly go to this pulmonary artery view, do the Dopplers. If my VTI is less than 4, it means it is functioning is less, the outputs are less. And then comes your LV functions, left ventricle functions. Okay, we have to calculate systolic function, diastolic function, and both together. For systolic functions for both LV and RV. And then if I talk about LV, okay, first and foremost thing, that video did not play, you have to look at, once you keep on doing an echo, you get to get the sense, how is the contractility, okay. So just by eyeballing, if you see, if your contraction is not good, it means your contractility is lower. Then comes your Fs, that is your fraction shortening. Then is your EF, ejection fraction. And then is this velocity of circumferential fiber shortening. Basically, this is a very good parameter. In newborns also it can be used because it is independent of afterload. Your Fs and EF and everything is load dependent. That how much is your preload, how much is the volume in the LV, okay, and how much is the afterload. That if your SVR, systemic vascular resistance, is high, okay, then that also can hamper your ventricle contractions. Okay, but I don't think so. We will be talking about that in this. Our main focus will be on 3 things: eyeballing, how to calculate Fs, and then how to calculate ejection fraction by Simpson's method, that is EF. Clear? And then diastolic functions, commonly we can do is, once after the lecture of PDA, you will see what is this EA ratio. These are basically the mitral valve Dopplers. You get 2 waves, E and A. Okay, so that is significant. The measurements and values are significant in PDA also, and in diastolic, it shows the diastolic dysfunction of LV also. And for systolic function of both, there is one thing which is tie index. I won't be talking about that because that is a bit more complicated thing. Okay, so just for nowadays in neonatology, for RV functions, what we commonly use is TAPSI. Okay, it can be very easily calculated. What is TAPSI? In advance, that one lecture is there, 30 minutes. I will talk about TAPSI in that. So one is eyeballing, okay, but the only issue is it is a very loose classification. It is very subjective. Okay, now I tell you, very commonly what happens is, I am a trained neonatal cardiologist. Okay, I haven't done any echo for a bigger babies or an adult baby person. So if I put a probe on 8-year-old boy, okay, the heart rate is half the heart rate of the newborn. So first thing I perceive is the contractility is not good. It is not the contractility is bad, the heart rate is so, for me it is a bradycardia. So my eyes are not tuned to that. My eyes are tuned to see the heart pumping at the rate of 120 or 140. So that's why it looks like that is this thing. So your eyes need to get tuned to that. So that is very important. So that's why it's very subjective. Okay. Can you see, compare these both apical 4-chamber views? Okay. So anybody can comment on this? What is the difference between both?
On the left side screen, the LV contractility is normal, and LV contractility on the right side is the very less contractility.
So you can very clearly see and compare. This one is pumping, you can see very nicely. There the functionings are very bad. And I've put a color also, and you can see a significant TR jet also there. Isn't it? So it is RA-RV has failed, and there that is doing contraction is very is normal. Clear? So if I talk about apical four-chamber view first, so we calculate our, like there are two views for calculating EF, ejection fraction. One is apical four-chamber view, one is two-chamber view. Okay. Ideally, you should be doing in both. In pediatric and adult, they do it in both. But in newborns, it itself, the reliability of EF is not good. Why it is not good? Because there is the shape of LV is not been, it gets modified and gets fixed over the time. Okay, so there are issues with the shape of the LV. So that's why again it is, this parameter is not very well standardized in neonatology. EF, ejection fraction. Okay, so that's why we don't tend to do it in apical two-chamber view. We tend to do it in apical four-chamber view. But commonly it is not being used in newborns. We commonly use FS to calculate the contractility of the heart rate, but we have to do it. When we talk about it, it is to be done by Simpson's method. The normal value is 45% to 75%. In machines, it is a very commonly, when you, as soon as you will do your FS, fraction shortening, if it is 30%, automatically EF will come as 60%. Because normally the EF is almost the double, 1.8 to 2.2 times your FS. But actual sense, it does not happen like that. But your machines will give you this number. So you should not be relying on those numbers, because in algorithm of the machine, it has been put like that. As soon as you calculate your FS, it will give you EF. As you calculate EF, it will give you FS. Okay. So, and then you have, for fraction shortening, you have two views, parasternal short axis and long axis view. And the normal value is 30% to 55%. Okay. So that FS, we do it, fraction shortening, we do it in M mode, in parasternal long axis and short axis. Okay. And for EF, we do it in apical four-chamber view. So parasternal long axis view, everybody is well versed. I should not be repeating it. This is how it happens. So this is your parasternal long axis view. You put a M mode, and that M mode line, like it should be almost vertical to the septum, one, and it should be crossing when your mitral valve flap opens and just hits it. It should capture your cavity and just at the edge of your mitral valve. This is how you will get. So this is in diastole, this is in systole. So when it is in systole, your mitral valve comes into the picture, and then it goes off in diastole because it moves away, it opens up, it moves away from this line. So this is the exact view where you calculate your FS in parasternal long axis view. So there in the machine only it has been the feed is been there. You calculate the diameter in diastole, you calculate the diameter in systole. Okay, so left ventricular end diastolic diameter minus left ventricular end systolic diameter divided by left ventricular end diastolic diameter into 100. That is what is your FS. But you need not calculate it. Machine will calculate it for you. Okay. This is what I have just explained you. Okay. In short axis, as sir already told, there are actual sweeps. Okay. There are sweeps in short axis view. So this is mitral valve view, fish mouth view. Yeah. What happens if you put a probe? You have to move it down. Starts with that Mercedes-Benz sign view. The next view is this. When you sweep down, it is mitral valve view, what we call as fish mouth view. Next comes the papillary muscle view. So this is your papillary muscle view. So this is the view in which you calculate your FS. And this is the last at apex, which is the apex forming chamber. Okay. So this is how again you do the same thing here. Okay. This is where your line should, in papillary muscle view, it should calculate. And then you calculate it. So that is fraction shortening. In pre-terms, FS is 25 to 40%, term is almost the same. The range is 25% to 55%. But again, I told you, it affected by afterload and preload. So it is load dependent parameter. So that's why it is becoming a big problem for us in neonatology, especially in pediatrics. So I'm doing my PhD, and my topic for that is we are doing it with the speckle tracking, because that again is load independent criteria parameter, and we are trying to see whether it gives some number to tell whether this is HSPD or not. Because to define HSPD, there are a lot of parameters. There is not a single parameter. So this is what I'm trying to see with speckle tracking. So again, this load is a issue, but this is what we have got for the present. But again, now the caveat is, if your baby is in shock with high pulmonary hypertension, so what happens in that? Your RA-RV gets dilated, isn't it? So your parational short axis view, the septum gets flat, or it has got paradoxical movement in your LV. It becomes like this. If that is the situation, your RVs are high and your septum is flat or invaginated in your LV, then it is not a reliable. You should not be doing FS in that. So this is by Simpson's method, apical four-chamber view. So this is parasternal, apical four-chamber view. This one, okay? And this is apical four-chamber view. Fine? I don't know why these videos are not getting played. Then you need, so what there we were calculating the diameters. Here we are getting the volume of the chamber. So we get to do the area. So it is to be done at end diastole phase and end systole phase. Ideally, you should be having a ECG here. That is the ideal thing. But if you don't have it, then this is when your chamber is biggest with your mitral valve closed, and your chamber is smallest when your mitral valves are closed. You calculate these two areas like this. Machine is, you have to rotate, map the area with this thing. And when it's get calculated, so it is your left volume of LV in diastole minus volume in systole divided by volume in diastole into 100. So this is how you get it. But as I have already explained, what are the issues with this? Okay, why? Because you get large errors because of the shape of the LV in newborns, especially in the preterms. Okay, and this thing we have just discussed. So your ventricle functions, eyeballing is being done. Okay, there is not a single, again, your VCF, your circumferential shortening is the one which gives you the afterload reading, assessment of the afterload. Or you can assess the afterload by speckle tracking or tissue Dopplers. That means, like suppose if you get a baby who is in shock, especially in the preterm babies, what happens initially? Your SVR is high, physiologically high. So LV is not contracting. So that means it is not the defect of your myocardium of your LV. It is because your afterload is so high, your LV is getting weak to pump the blood against that high resistance. So these parameters will not give you that effective data or measurement. That is it because of myocardium of my LV, or it is because of high afterload. The only thing it will give me that my functioning contractility is low. Okay, if I try to do the LVO, left ventricular output in that, it will be low. The only thing is, if your perfusions are bad, your invasive blood pressures are high, and your cardiac output is low. So that will give you indirect indication that your afterload is high. So that in that case, you need to start inodilator. You need to start milrinone or dobutamine. If you start dopamine in that baby, that will be bad in that baby. You got my point? Again, this 4-chamber, 5-chamber views. So this is for diastolic functions of LV. So which is this view? Apical 4-chamber view. So this is my color Doppler window. Where I put my color Doppler window? Mitral valve. So what I will do is, I will put my pulse wave Doppler just below mitral valve in the LV here. And this is what I will get. So two waves I will get, E wave and A wave. Okay, this is my E wave. E wave is because of the passive flow of the blood from LA to LV. You got why it is passive? As soon as your mitral valve will open, by virtue of presence of volume of blood there, it will go down. So that is one wave. Then my contraction will start. So that is the A wave, when the blood flow from atria to ventricle by virtue of contraction. Okay, so the normal value in preterm it is 0.81 and in term it is 1.12, around 1 to 1.2. Okay, if in preterms your EA ratio is less than 0.6 or in term it is less than 0.7, it is suggestive of diastolic dysfunction. And you know why it happens? E wave, why the ratio will be low? Because the velocity of E wave will be low when your diastole does not happen adequately. Okay, agar मान लीजिए, just suppose this is my LA, this is of uniform size. My LV is opened this much. There will be a lot of difference in the pressure, isn't it? So more blood will flow from LA to LV. If it is not gone this much, it has gone only this much, the difference will be less, the velocity will be less. So it is diastolic dysfunction, it is telling. So my EA ratio is less than 0.7 in term, 0.6 in preterm, it is diastolic dysfunction. Fine. And this is my right RV functions assessment. So what we do is we will talk about that in that lecture, tissue Doppler or speckle tracking, and then you can calculate the ejection fraction in RV, but it has to be in the special view. What sir was telling, 3-chamber. It is right ventricular is 3-chamber view. This is what we call as the 3-chamber. This is for RV, not LV. For LV it is 4-chamber and 2-chamber. For RV it is 3-chamber view. And then it is TAPSI. This is what basically, because when I try to do the volume area of your RV, again it is a very bad thing, because there are two limbs of RV. One is anterior, one is posterior. Around 30 to 40% of the volume of blood is in the posterior chamber, posterior that horn of RV. So that is because of the structure of RV. That's why. And this is the TAPSI we will talk about. This is incursions of this we will talk about in that lecture. Okay. And then comes the preload, IVC. So this is your where you should keep pointer pointing at 12 o'clock, upper 1/3 and lower 2/3 of the line joining your Xiphi sternum and umbilicus, and this is how you will see your IVC. IVC again is it variable with the respiration, so again you have to do it with the M mode. Okay, and again you have to calculate maximum minimum diameter as you did it in SVC, and this is the interpretation. This is for the term babies. If the maximum diameter IVC is less than 8, collapsibility is more than 50%, it is because of your hypovolemia. It is fluid responsive. Diameter less than 8, collapsibility is less than 50%, it may be lower range of the normal. Okay. Maximum diameter is 8 and more, collapsibility is less, it means it's distended or it may be normal. So this variable will not be reliable if your baby is on very high ventilatory pressures. Your PIP is more than 20 or on high frequency ventilator, or your RV has failed. If your RV has failed, your IVC will be engorged. Then again, it will not be a reliable parameter. Fine. So in summary, in shock measurement, apical 4-chamber, you do eyeballing, and then you do the mitral valve Dopplers for EA ratio for diastolic dysfunction. This is for the contractility. Fine. In 5-chamber, what you do, you calculate the Dopplers of aortic VTI to calculate your LVO. In Paston long axis view, you do the aortic diameter. This is again will help you in calculating your LVO. And then in that, you do fraction shortening to calculate your contractility. Then comes the parasternal short axis view. You have to see for the diastolic dysfunction or for RV for interventricular motion. Then again, you do the FS in that. In high parasternal views, you calculate the size of SVC. And then Subcostally, you calculate the SVC flow. You can even do it in high parasternal views also, but that is a modified view. Just for keeping it simple, I have not shown you that view. But even you can do the calculation of VTI of SVC in the high parasternal views also. And then for subcostal views, you do the diameter Dopplers of SVC and see the preload for inferior vena cava. Clear? So this summarizes the whole in which view what you have to see for assessing the shock. And this is just to give you a glimpse that how the, see, this is what we are doing from the echo, this is what is the clinical. Higher normal blood pressure, higher normal cardiac output. Need not do anything. Low blood pressure is high output. It means there is a shunt. Okay, need to treat the shunt. Normal high blood pressure is low cardiac output. That shows your afterload is high. Use inotrope. Low blood pressure, low cardiac output. The most common reason for this maybe in shock is septic shock. So septic shocks are mixed shock. You need to start both inotrope and vasopressors. Okay. So this is all we have. So you should have been a target approach. Target we always talk. See, she has missed her target, isn't she? But she is a very determined learner. So she will never let her target go off. Always hit the target. Thank you.
We'll start. No problem. Thank you. So good afternoon. I just want, before I start talking about this patent ductus arteriosus, we all know that this is one of the important morbidities we all see in the neonatal intensive care unit, correct? I want to know how many of you use echocardiography in your unit? Okay. And you all want to see PDA, correct? Whenever a sick baby comes, especially the preterm baby, you want to see, correct? So you all know, I think this group has echo in the unit, and you're all using the echo for the determination of patent ductus arteriosus. Am I right? Okay. So we all know this parable. This is a very historical parable, and this parable clearly indicates that an elephant with blind men, correct? We're all blind men looking at the PDA and each talking about one component and saying that this is right. But at the end of the story, you believe or not, we are all at wrong side. So what does it indicate? That you need to take as a comprehensive rather than taking one point and say that, yes, this is a PDA which is hemodynamically significant. Next slide, please. Yeah, here's a disclaimer. I am neither a radiologist nor a cardiologist. I'm just a newborn physician who has passion about the neonatal hemodynamics using bedside ultrasound as an extension to the physical exam, which is very, very important. Never forget your basic MBBS. Read Guyton and basic MBBS, very, very important, where history is given paramount there, the importance, correct? So this is an extension to physical examination. When you talk about echocardiography, don't go, the take-home message here is not that you go and do the echocardiography, it is to learn the physics behind it, the physiology behind it, and as the previous speaker said, actually, all what the mind doesn't know, the eyes cannot see, make sure that you fill up the physiology in your mind, then you can do this. Next slide, please. This is from a plea from a sick neonate. I, a sick neonate requiring more attention and time in the intensive care unit, make a plea that kindly give me care using your wisdom and technology for my overall development. You are my friend indeed from birth, and I know that you would constantly monitor me as a whole. I change constantly, that's very important, and you look at the change and set me right. Probe me with the sterile probe with warmth and gentleness and prove that you indeed correlate clinically. See, again, ended with clinically. So make sure that your gentleness is very, very important. I am very sad to say that when somebody comes from outside, the way they do the ultrasound, an in-house fellow doing ultrasound entirely different. This is a parallel circulation. Nobody hand wash, no sterile taken, and no wearing of sterile gloves. They just come and do it. They are so hurry. The cardiologists should have very cool heart, but we have not seen that. So moment they come, the echo machine should be there, and they start shouting at it. By the time the normal PDA will become hemodynamically significant PDA for both of them, and baby will be at fault. That is very, very important. Calmness and quietness, gentleness with sterile precautions, very, very important before you jump into diagnosis secondary. If I don't do diagnosis, somebody else will do that. That is not the good thing. Okay? Next slide, please. Okay. Yeah. So three objectives. That's what given to my this one. So echo parameters, PDA assessment, and PDA management. I'm not going to talk about PDA management. How it is useful in managing the hemodynamically significant ductus arteriosus. So as you rightly see, that is a three-leg sign. What you see, the pulmonary artery, two branches, and you see the red jet. What you see, that is the third leg. That is the rectus arteriosus. Okay, next slide, please. So why this topic chosen? Always you go to any conference, PDA, PPH, and shock. PDA, PPH, and shock. Even if you see after 10 years, you'll be talking about the same thing and something new added, and then again it starts. Why this topic? Every conference has this topic, we know. Thousands of publications. Go and see that. Oh my God. PDA and neonatology, if you put PubMed, you get lots of things. And you see there, everything is repeated. One or two things this way. If you know it is in the active form or passive form, something like that. Otherwise, most of the literatures commenting on the same thing. Yet being debated amongst neonatologists, cardiologists, and surgeons regarding the management. Is any concordance? No. There's a lot of discordance. You don't believe that, he doesn't believe that. Surgeon will be waiting with the knife actually to do the surgery. No, this baby requires ligation. That's how the thing. And always you know that we three things we use. And wherever you go, first thing is what? Clinical. And then comes actually your echocardiography, the biomarkers. Nowadays, the biomarkers, my God, I don't know what is the 28-week biomarker level. Actually, those things we do, correct? That tetrapeptide, dyspeptides, and we don't know. And people now they say that, hey, don't worry, you do peptide, look at the peptide and treat the baby. And they forget the baby only. And baby are 25%, 30%, oh, peptide is abnormal, I think we should treat this. So that is very important. I don't know anyway. More and more get a lot of confusion. At the end, poor neonate at the mercy of treating physician, whether he's a cardiologist or a neonatologist or a surgeon. Next slide, please. So we all know that I don't go much into the detail. Fetal circulation is a ductal shunt, we know that. Duct is present inside the uterus, duct is present outside the uterus. Duct present inside the uterus is always right to left, correct? That will get changed into bidirectional depending on the pressure. Because it has to get equated before the systemic pressure increases, pulmonary pressure will become equated to systemic pressure. That's how you see what is called bidirectional shunt. Of course, at the end of the story, the systemic pressure goes up and the pulmonary pressure comes down. That's how you'll find the left to right shunt. This is very, very important in the management. Do I treat a baby with right to left shunt? No. Do I treat a baby with bidirectional shunt? No. When, suppose if you want to treat, it should be left to right completely. This is very, very important take home message. And of course, there are a lot of things contributing for this. The antenatal steroids, gestational age, mechanical ventilation. Of course, nowadays, if you see a lot of literature on low platelet count, and people, they started doing, oh, it's low platelet count, then do the platelet count in newborns, and platelet count is low. And you see a lot of babies with no PDL, low platelet count. Some PDL, low platelet, you treat it. Then they thought, oh, we give platelet transfusion, you will not, this PDL becoming hemodynamically significant. There are people, they gave platelet also. Then somebody wrote, it is not the number, it is the function of the platelet which is very important for the closure of ductus. You understood? It is not, even if it is 40,000, and even if you make it 1.8 lakhs, but still actually PDA is significant because they said it is not the volume you are going to increase, it is the functioning of the platelet. If the functioning of the platelet is not good, that is one of the contributing factors for the patency of this ductus arteriosus. Next slide, please. So I just start with a neonate. A preterm neonate born at 29 weeks of gestation required, as usual, the oxygen requirement started to increase with pinkish secretion in the endotracheal tube. The pericardium active with murmur. The blood gas showed metabolic acidosis. The heart rate was around 190 beats per minute. Low diastolic blood pressure. The dorsalis pedis artery was well felt. The chest X-ray demonstrated pulmonary edema. The sepsis was ruled out. So it is a common scenario. I think we all know that this metabolic acidosis and the high requirement of the parameters on the ventilator, they all go in favor of patent ductus artery, which is significant. Next slide, please. So this is what exactly I want to tell you. This is how the clinics, we look at the tachycardia, we look at the wide pulse pressure. So this is very important, wide pulse pressure. We always look at what is systolic and diastolic. Remember, what we see is the diastolic, very low diastolic flow. But if it worsens even the systolic, remember that's what they say. You may say that systolic blood pressure is normal, diastolic pressure is going up. That's what you see, correct? But in the later part, very high, if you don't manage these babies, then systolic blood pressure also starts coming down. This is another important clue here. Of course, these are all the things what I mentioned in my previous slide. Next slide, please. So worrisome PDA. So 3 things, remember. If I want to worry, look at 3 areas. One area is, you look at the system, whole body. Then you look at the brain. Then you look at what is called as your lungs. So these are 3 important areas you need to look at. That means what I'm going to talk to you is, am I dealing with a baby with hemodynamically significant PDA contributing for systemic undercirculation? Or am I seeing a baby with, whenever the underperfusion happens, definitely there will be over perfusion into the lungs. This is another thing. So these are the 2 important. Second thing, actually, the poor fellow who is there at the top also will get affected. So 3 areas where we are looking at the hemodynamic significant PDA with respect to the mortality and morbidity is 3 areas. Next slide, please. This is what exactly the echocardiography. We all know that. I don't want to go into the detail. You know, it is a focused one, the bedside, and you can see that, you know, how the physiology, it helps actually. It is not just you do once and go away. You can keep on doing, isn't it? So those things actually will tell you that whether your clinically correlation and also when you manage these babies, whether it is going to help in the assessment. Next slide. So these are the important planes. And you all know that most of the planes, what we use, the parasternal short axis, parasternal long axis, then you use subcostal views, and the 4-chamber views and 5-chamber views. And of course, the suprasternal views and modified suprasternal views. These are all things I don't want to repeat, already repeated. Next slide, please. So what we are interested in is ductal characteristics, pulmonary overcirculation, and systemic undercirculation. Okay, next. So when I say ductal characteristics, you look at the ductal size. First thing is whether the duct is present or not, and what is the size of the shunt. The next is the direction of shunt, of course, the gradient. So these are 3 important parameters when you see the characteristics of the duct. So presence of duct, and what is the duct diameter, what is the direction shunt. Is it actually the right to left shunt, bidirectional shunt, or left right shunt? That is very important for us to decide for the management. Of course, the gradient is also important. Next slide. So this is on short axis view. You can see that the 2D echo showing actually 3 left sign, and you can see this PDA here, the color Doppler. Here one should be very careful. This is very interesting on short axis view to know that ductus is present or not. But it's not a good view to measure the diameter of the ductus. Because what's happening there in the short axis view, you may actually measure the left pulmonary artery also. So how do you know that you're measuring only the ductus arteriosus? For that, this view, what I have put actually the 2D echo first one, the below that, you can see that that is the pulmonary artery and the descending aorta. You can see that. This is the one. This is a modified suprasternal view. This is called ductal view, where this is the pulmonary artery, this is a descending, and you can measure here. So for the measurement of ductus, always the modified ductal view is important. It's called suprasternal view important. So that's how you can see that. This is actually a mode you can put when you put actually a mode over this color Doppler. You can know that whether it's a bidirection shunt. You can see it's a bidirection shunt. You are seeing both the red jet and blue jet. So it indicates the bidirection shunt. You can still wait before you treat the baby. You can still why? Because I'm still actually at the level of bidirection shunt. Next slide, please. So there are different patterns. People, they looked at, oh, shall I take the Doppler and treat the baby? So, if you see that Doppler, PDA, neonate, you get a lot of things. And they looked at what are the different types. As soon as the baby is born, it should be completely right to left. But by nature, you don't see. As soon as the baby is born, we have done actually in the delivery room, you put the probe immediately at birth, but still it is PPH type. We don't see the fetal circulation so fast. Once you disconnect the placenta, once you cut the umbilical cord, you'll find some amount of PPH type will happen, where you'll find in PPH type what happens? You get the pulmonary flow will be deeper. This is the right to left shunt, down one. The upper one is the left to right shunt. You see the deeper portion of that is from the pulmonary artery, because pulmonary resistance is still there. That is the reason the flow is also, the down line is also too much. But as you move on, it starts growing. But the children, once they start growing, they start dancing also. So once you see the dancing phase, this is the growing phase. This is called as pulsatile. They start dancing. What do you mean by that? You mean that if I see a PDA, you see like this, the first one, I measure the systolic and diastolic part of it. If the systolic and diastolic part, if they are very close to each other, it is restrictive PDA. That I'll show you next. If you see the difference between the systolic and diastolic, if it is too much, less than 50%, then it indicates that left to right shunt, it is significant, because there is pulsatile type of PDA. Then of course, whether you manage, most of the babies without management also, they start closing. So you may get closing. Of course, the closed ones, you get only the pulmonary flow. No, this is how the pattern of, there are 5 important patterns you see in ductus arteriosus. This you can appreciate as you keep doing everyday echo and see that what is the pattern, what is the pattern, what is the pattern. Okay, next slide, please. This is what exactly I was talking to you about restrictive and unrestricted PDA. So very important to know that in restrictive PDA, look at the systolic and diastolic. If they are very close to each other, it is always restrictive. If they are away, that's what exactly I wanted to show you, that how the non-restrictive ductus arteriosus serves. Okay, next slide. Yeah, so I told you 3 things. One is the brain, the other one we are worried about the lungs, and the other important thing is the intestine. Now look at this assessment of pulmonary overcirculation. So what exactly, we all worry with respect to PDA, my lung should be good, isn't it? So if you look at a lot of literature, they only looked at the lung, they looked at the brain and the intestine. Here, if you look at what are the ways you can assess the increased pulmonary circulation. When I say increased pulmonary circulation, what do you mean by that? If perfusion, if the circulation is more in the lung, which part of the heart is affected more? Left top. That's the reason I wrote left atrium and left ventricle, they are dilated. So if you see on the echo, if the left atrium and left ventricle, they are dilated, so think of that, because pulmonary veins is bringing a lot of blood to the left atrium to left ventricle. That's one part. When it is coming too much blood into the left atrium, what will happen to the left atrium volume? It increases. So when the left atrium volume increases, what will be the ratio? It increases. So if it is more than 1.3, 1.4, the left atrium become bigger, so then the LA-AO ratio. Most of the times actually, if you see the LA and AO, almost they are same. If the left atrium starts increasing, the LA-AO ratio also starts increasing, correct? But there are limitations. I don't want to go much into the detail of limitations. So what are other factors which cause left atrium? You know that there are a lot of other factors in the cardia where exactly you see the left atrium enlargement happens. Next important thing, talking about what is called as mitral E by A ratio. You think that, again I'll repeat it, 70% of the blood, if you read Guyton text, all must have read Guyton textbook, I think. So 70% blood from left atrium to left ventricle does not require any exercise. just it goes. When it goes, just it goes, what will happen? What will happen to the E? Is it high or low? Because maximum is going there. That is the reason if I go and get my heart checked, echocardiography, what will happen to my E? E is high. It is normal. Pediatric age group go, it is E is normal because I am sleeping like God and everything is going. Only 30% of the blood requires the contraction of the left atrium. That is the reason E is big. But in neonate, it doesn't happen. Why it doesn't happen? Because baby is tachycardic. My heart is 70 beats per minute, but heart rate of the baby is 140, 160. How do you expect this diastolic function is good? So diastolic function is not good. When diastolic function is not good, how do you expect this E to be on the higher side? So E should be lower than the A. Are you clear about that? So E by A in a preterm baby is lower. How lower? Again, like 0.8, 0.9. So in an easy way, remember always 1, less than 1, and you can think. But in adults, actually, it is in pediatric age. That's what I have written here. What will happen, actually, the first one is normal. And what happens, actually, the middle one, the yellow one, is E by A ratio is on the higher side, 1.1:1. And again, if you see, it is normal in a child. Clear? So this is how the E by A ratio has been taken. And this clearly, this is called transmitral flow of blood. And you do pulsar Doppler over that, and you get this. The next important is the left ventricular flow. Left ventricular flow, one diameter, one flow is important. That also discussed. I don't want to go much into the detail. Next slide, please. So after knowing the lung over circulation, we are also interested in looking at systemic hypo and post-ductal aortic blood flow pattern. So important vessel, you take one brain, you take gut vessels. So gut vessels, you can do celiac, supramesenteric artery, and you do also the abdominal aorta. So look at the inferior vena cava, superior vena cava, look at the gut vessels, celiac trunk, and the supramesenteric artery, in addition to the abdominal aorta, and of course, the brain. Next slide, please. Yeah, this is how you do. So it's a subcostal view, subcostal sagittal view. Just a little bit tilt to the left, you get both the arteries. You can see the abdominal aorta here. And what you see, the first one is the celiac trunk, and next to that is your superior mesenteric artery. Correct? The next thing you have got what is called it's called Tyrian portion, the transtemporal shooting. You get actually the middle cerebral artery going towards the probe. That's the written red. That is the middle cerebral artery. And then you have got superior vena cava. You can do both. You can do superior vena cava. You can do both the diameter and the flow. There's no need for going subcostal view. Nowadays they say that it is always better to do, but you have to get the modified view, and then that's how we do. So you get, but if you look at it, is almost the angle of insonation is very, very less. You can do it. So there you can look at the diameter and flow and calculate. And what we are looking at, is there any increase in systolic flow or diastolic flow, or it is there an absence of diastolic flow or reversal of diastolic flow. If you see reversal of diastolic flow is not good. If there's no diastolic flow, is also not good. If the normal flow, it is normal, correct? So in all these vessels, look at resistive index. So look at the peak systolic velocity and diastolic velocity, then you can calculate. Are you clear about that? This is how you have to do. Next slide, please. So PDA end organs, that's what I told you. These are the three important end organs we have looked at. Next slide. So another important thing, you know that now you have satisfied that you are asking the surgeon, you have given already the paracetamol, indomethacin, ibugesic, repeated doses, but baby is not improving. Now either the cardiologist will do coiling or the surgeon is waiting for the ligation. Now the ligation you do, very important, most of the times actually post-ligation babies they start deteriorating. This is called post-ligation syndrome, very, very important, where the echo will suddenly what is happening? you are giving more blood to the left ventricle and it goes into shock. So here, the detection of the shock post surgery is very essential, and you can do it early and then treat it also, and they all improve. That's very important. Next. So keep PDA. Another important thing, we are so much happy to close, but be careful before closure. If I say there is PDA, oh, close means the chapter is closed. Because if you have a baby, we had a baby yesterday, born 28-weeker, and this baby had antenatal-diagnosed transfusion of great vessels. We knew that. Suppose the baby comes without any antenatal diagnosis, and you see saturation, you see big duct coming, okay? And then what do you think? Oh, it's a preterm, we treat it. So you give paracetamol or ibuprofen. Then see that instead of you waiting for the improvement, you start looking at the deterioration and baby dies. First of all, 70, 60 saturation and baby dies because there is a duct dependent lesion. Similarly, this is one important thing you can see that this is a pulmonary atresia baby, where you can see that the right atrial enlargement, very small right atrium and right ventricle, and we want to keep this PDA patent. So what did they do? They did the stent. So this is a baby we had 3 weeks back, and this baby did very well. That means the take-home message is, moment you say PDA doesn't mean that you have to close, and you should always look for, and it is an essential connect in cyanotic heart disease. Okay, that is another important thing. Next slide, please. This is what we did a study. We were calling, when I joined Manipal Hospital, where we used to call everything. PDA present? Yes. 3,000 rupees. Is it increasing? 3,000 rupees. Is it actually medication given? Still it is present? 3,000 rupees. We started calculating how much money the baby for PDA evaluation gets. It's around every baby 40,000, 50,000 only for the PDA. Then we thought actually how to cut down. Cardiologist is called for the sake of finishing. We all know, unless you know the anatomy, the 2D echo properly, the brain, you cannot assess this also. But still, we wanted them to give a clean check that there is no cyanotic heart disease, correct? Once it is ruled out, then remaining ultrasounds we started doing free of cost. We could bring down from 100 rupees to 20 rupees, so 80% we saved. We published this actually recently, and where, so you can see the baseline intervention period so well, and you see the cost, how much you could bring it down. So this is another important study, but remember that it needs a lot of hard work. You have to stay in the unit, keep doing, and have the help of great cardiologists, especially make friendship with echo technicians. They are the best people, always available, and then you can learn quite a lot, keep doing, that's very important. Next time, please. So take-home messages, we all know that it is a common morbidity. Presence of PDA does not mean close. Clinical assessment is the basic foundation before the use of technology. More and more hands-on training is essential in acquiring the depth of knowledge. Rule out duct-dependent lesion before considering the closure. Knowing everything is a knowledge, but the wisdom lies in the treatment. To me, the PDA is poverty in defining and assessing significant ductus. Thank you so much. Next slide, please. Yeah, this is my team. These are my books. If you are anybody interested in getting the book, it's available. The counter, you can get it. Thank you so much.
Thank you, sir. No, thanks for your excellent talk and your thanks a lot, sir. Actually, we are all going with some take-home messages. Move on to next Dr. Pooja, neonatologist on our sheet. She's going to talk on pediatrics.
We'll move on to the next topic. I'm asked to speak on PPHN, how functional echo helps in assessing PPHN. I'm Dr. Bujata, consultant neonatologist from Andhra Hospitals. And I also thank the organizers for giving me this opportunity. So we'll start. So what are we going to do in the next 30 to 40 minutes is we'll introduce ourselves to the topic. We'll see the pathophysiology, because unless we know the pathophysiology of PPHN, it's very difficult for us to manage PPHN. And we'll see how echo is going to help us in diagnosing and managing PPHN. And management will just rush through and we'll finally sum up. So, see, all neonatologists will be familiar with this topic of PPHN. So that's the reason I have written it's very familiar, and I would like to call it as a very fascinating diagnosis, because as we can see, every other disease in newborns can finally lead to PPHN and making this PPHN as a Superman. And we find it difficult to treat this Superman at the end of the day. So any disease you take it, your sepsis, meconium, RDS, hypoxia, hypothermia, pneumonia, if not properly managed, can finally lead to PPHN. So PPHN is nothing but a syndrome of circulatory maladaptation at birth, and the occurrence is about 1 to 2% per 1,000 live births. All babies with PPHN are either term or near term, but even 2% of preterm babies, you can have PAH. So the mortality is around 5 to 10%. So as I said, unless we know the pathophysiology, it's difficult for us to manage. So always PPHN, it has to be a physiology-based approach. These theory slides will just rush through. We have primary and secondary. Primary accounts for 10 to 20%, where there is abnormal remodeling of the pulmonary vasculature. And secondary PPHN is basically maladaptation and underdevelopment of the pulmonary vasculature. Next. This also will skip. This is all theory part. What is the causes of secondary PPHN, acquired and congenital? Will skip. So as I said, we all should know the pathophysiology of PPHN. Don't worry about this slide. Next slide. See what happens. You have hypoxia, you have ischemia, you have got placental insufficiency. At the end of the day, what you have is increased pulmonary vascular resistance. So this one term we all should get into our brain. So what happens when there is increased pulmonary vascular resistance? Obviously, there will be decreased pulmonary blood flow. And once we have decreased pulmonary blood flow, there will be decreased return of oxygenated blood to the left heart. And finally, there will be decreased blood to the end organs, which again lead to decreased end organ perfusion, tissue hypoxia and acidosis, which both the hypoxia and acidosis again are both potent vasoconstrictors. So they finally again will cause increased pulmonary vascular resistance. So then a vicious cycle is set in. So just remember, in any baby with PPHN, we have increased pulmonary vascular resistance. The cause can be multifactorial. So we need to properly treat hypoxia and acidosis. And another important thing we often miss in managing PPHN is we need to know the cardiac function while we assess any baby with PPHN. So what happens, as I said, when there is increased pulmonary vascular resistance, obviously your right heart gets affected. There can be right heart dilatation because of the increased afterload. It can be right heart hypertrophy also, and there will be right to left shunt, resulting in decreased pulmonary blood flow. And meanwhile, with your right heart dilatation, what happens is there will be septal deviation. So this septal deviation again can cause decreased left ventricular filling. So there is decreased preload, and because of that ventricular interdependence, again you can have left ventricular dysfunction also, which again will cause decreased systemic blood flow and decreased end organ perfusion, and again which again can lead to increased pulmonary vascular resistance. So always assessing any baby with PPHN, just remember to assess the cardiac functions also. Next. So as I have said, these are the hemodynamics one should always keep in our brains, because unless we know what we should look for, we don't be seeing in the echo also. So we need to have a measure of the increased pulmonary vascular resistance, which is technically not feasible with our echocardiograph. So what we will do is, we'll measure the pulmonary arterial pressures. And we have to measure both right and left ventricular function. Again, if left ventricular fails, we can have pulmonary venous hypertension. These are the pathophysiology, hemodynamics involved with PPHN. So the basics. So two formula which we have to remember. One is the Ohm's law, which pressure is flow into resistance. So as I have said, we can't measure pulmonary vascular resistance. So what we measure is the pulmonary arterial pressure, which is related to the flow into the vessel and the resistance. So remember, your pulmonary arterial pressure is not equivalent to the pulmonary vascular resistance. And next one is the Bernoulli's equations, where pressure is 4 into the velocity square. Because this formula we need when we calculate our pulmonary arterial pressures. So we get into the topic proper with this background. So what are the things when you look for when you do the functional echo and we are suspecting PPHN for that baby? So first is the visual assessment. Then we will calculate the pulmonary arterial pressure using our triage jet, that is a tricuspid regurgitation jet. And if the baby has PDA, assessing your pulmonary arterial pressures becomes very useful with the shunt velocity. Then other component is pulmonary artery acceleration time, or the time to peak velocity, and time to peak velocity with RVAT ratio. And next, the last one will be your septal morphology. How is your septum moving? Next. So this already discussed by Dr. Mohit and all the speakers who spoke just before me. So on visual inspection, first video. So this video itself we can see. So first video, the contractility appears to be good, but there appears to be right atrial and right ventricular dilatation. So the contractility appears to be good. But in the second video, there appears to be a decreased contractility of the left heart. So how this has already been mentioned, this is observer dependent. For someone it may appear to be normal, and some it appears to be abnormal. This we get with lot of training and lot of the number of echoes we daily practice. So the first one is the visual assessment, which is done in the apical 4-chamber view. Apical 4-chamber view, one tip which I would like to suggest is, so what I want to highlight is your interventricular septum has to be straight, because who are new to this, they often end up doing the subcostal views and assessing the ventricular function in the subcostal views. So proper apical 4-chamber view, your interventricular septum should be straight. It means you have to get it in, you have to get exactly perpendicular in the window. Next slide. So once we have assessed with our eyeball whether there is right heart dilatation, then we will calculate the pulmonary arterial pressure. So how we do that? We calculate the TR jet velocity, which is again done in the apical 4-chamber view. Apical 4-chamber view positions, again we are not doing, that is basic echo. Remember, you get your IVS straight in the midline of the window. Then calculate your right ventricular systolic pressure using the formula 4V square. We have to add up our right atrial pressures also, which we take roughly 3 to 5 millimeters of mercury in the newborn. So this, play the video. See, this view why I have put it is, this is not the proper view for measuring the TRJ, because the heart is inclined, still the heart is in the sleeping position. As I have said, your interventricular septum, we can see a TRJ over here. If we put a Doppler over there, my sampling gauge should be exactly parallel, or we can allow up to an angle of 20 degrees, not beyond that. So always try to get your IVS interventricular septum straight. Okay, so now the second picture we can see my Doppler angle I have put, and I have calculated my TRJ. This is my TRJ. So look for the TRJ. TRJ is always a beautiful envelope. Okay, we have to get a beautiful envelope, then only our measurement is going to be right. So once we calculate the velocity, get your cursor over here and to the tip of the velocity. So it is 4V square, and with add your right atrial pressures. So Nietzsche, I have done the calculations. So for this particular baby, your right ventricular systolic pressure is coming around 64.5. So measurement of TRJ, remember to get a proper apical 4-chamber view and get your Doppler angle right. It has to be parallel or accept a minimum of 20-degree inclination. Next slide. So as I said, the pitfalls will be for the beginners, getting your 4-chamber and remember you have to use a continuous Doppler while measuring your TRZ, not pulse Doppler. And your angle of inclination should be less than 20 degrees. And always calculate only when you have a proper envelope, jet envelope. So in that view, which I have showed earlier, when my heart was still in the sleeping position, when I tried to calculate, even though the Doppler angle seems to be normal, when I tried to previous slide, when I tried to calculate the TR my jet envelope was not correct. So even though if I calculate here, we get a wrong measurement of the pulmonary arterial pressures. So try to remember these things. Get your 4-chamber right. Get a proper envelope. Angle of inclination should be completely parallel or less than 20 degree. Then only calculate your pulmonary arterial pressures. Next slide. So the most common thing is for us it's like you have PAH, you need to have a TRZ. No, does absent TRZ rule out PPH? It's not always like that. So there need not be a TRZ always for us to diagnose PPH. So when we get a TRZ, always confirm this TRZ in another view also, which is the right ventricular inflow view. I hope all of you will be clear, will be knowing about that view. Next slide. See, once you are into the Planck's view means your marker is onto the right shoulder. Your probe marker is onto the right shoulder, longitudinal view. Once you get that view, just tilt your probe towards the liver. When you tilt your, see, if this is the probe, and my marker is this side. Once I get my Planck's view, what I tilt my probe towards the liver. So when I tilt my probe towards the liver, I will be opening the right atrium and the right ventricle. See, this baby does not have a TRZ, so the TRZ is not visible. So this is the RV inflow view. So in your Planck's view, just tilt your probe towards the liver, you will have an RV inflow view, where again you can get a TRZ, there again you can put the Doppler, and because the Doppler angle will be always parallel, so then you can get your because the baby is not having a proper TR, we are not getting a proper envelope. But if the baby is having significant TRZ, here also we will get a beautiful envelope and we can calculate our pulmonary arterial pressures even from this view. So if you are not getting a TRZ, proper angle in apical view, because once some babies might be ventilated because of PPHL or due to any other cause. And when your lungs are inflated, it's very difficult to get a proper apical 4-chamber view. Then this view becomes very handy for us. So always try to learn this view also. Right ventricular inflow view. Next slide. So once we are done with your TRZ, then another parameter which helps us in assessing the PPHN is the ductal shunt. All babies need not be having a PDA, but those babies for whom we have PDA, we can even calculate pulmonary arterial pressures from the ductal shunt also. So if PD is present, first see if it's a left to right or a right to left shunt. Whenever we have PPH, it always is right to left or a bidirectional shunt. But remember again, a right to left shunt always rule out some cyanotic congenital heart disease. Then only think of PPH. As this always been highlighted by previous speakers. Again, important things are measure the velocity in the ductal view. And then go for the color Doppler, and here we always go for a pulse wave Doppler. So these are the settings we use. Use the ductal view, put the color Doppler in the sampling gate in the color Doppler, and then go for the pulse wave Doppler. So just see here, for that baby, it's a red color. That means red means Doppler basics everyone will be knowing. Red is towards the probe. So that means the baby is having a left to right shunt. So left to right shunt means your systemic pressures are higher than your pulmonary pressure. So you can rule out your pulmonary arterial hypertension. So when you suspect PPHN, you have either you have a bidirectional shunt like this, or you have a plain right to left shunt. So here it's bidirectional. Now we'll get confused whether to take which way. Is it a left to right or a bidirectional? Then calculate the how how much component is your left to right shunt. If this component is more than 30%, then you take it as right to left shunt. And how do you calculate that? You take the time from the beginning of the cardiac cycle to the end, and the timing of the systolic timing. So if this is less than 30%, then that is left to right shunt. If it is more than 30%, you take it as right to left shunt. And how do you calculate? Again, you measure the velocity, the shunt velocity. Keep your marker, measure the velocity 4v square. Otherwise, automatically you will get a pressure gradient as we get in TR, right? So get the velocity 4v square and you add that to your systolic blood pressure. The baby will be being monitored for the blood pressure, either invasive or non-invasive. So add your pressure gradient with your systolic blood pressure, or you can calculate it with the velocity itself. Hope I am clear with that. So see whether it's a left to right shunt. If left to right shunt means PPHN, we need not worry. If it's a right to left shunt, see if it's a bidirectional or a pure right to left shunt. Pure right to left shunt, we don't be having any dilemma. We can calculate the velocity. You go for 4v square and add to your systolic blood pressure. If it's a bidirectional shunt, calculate how much of the component is your systolic component is your right to left shunt. If it is more than 30%, then take it as a right to left shunt and you can consider you can add it to your systolic blood pressures. Okay, systemic blood pressure. Sorry. So another useful component which helps us to assess to see if there is a PPHN is flow across your patent foramen ovary. So again, across PFO, if it is a right to left shunt, please rule out some cyanotic congenital heart disease. This all the speakers have already highlighted, but again, any right to left shunt across PFO, rule out cyanotic congenital heart disease. In PPHN also we can get right to left shunt or a bidirectional shunt across the PFO. So the same may be, this image shows a left to right shunt, the first one, whereas the second image shows a right to left shunt. So the baby was having a bidirectional shunt across the PFO. So that's the reason I have used the terminology like it's a non-specific. We just get a clue whether the baby is having PPHN or not. Next slide. So this is the bidirectional Doppler waveform which we get. Next slide. So once we know there is a component of PAH and we try to measure your pulmonary arterial pressure with a TR velocity or with your PDA shunt. So how will we grade that? If it's less than 35, we take it as normal, and if it's 35 to 45, we take it as mild. If it's 45 to 60, we take it as moderate, and if it's more than 60, we take it as severe PAH. So we have completed our TR jet velocity. We know now how to calculate using our PDA shunt velocity, and we will get a clue by looking at our PFO, whether it's a right to left or a left to right. Now, what is the other parameter which helps us in assessing whether there is PAH or not? Sometimes clinically we feel that this baby is having PAH, but we won't be getting a proper view because the baby is on ventilator or the baby is having high peaks. We will not be getting the proper TR. Even in the RV inflow view also we will not be getting the proper TR. So what are the other measures we can rely for calculating? We can't calculate pulmonary arterial pressures with these views, but at least we can know whether there is PAH or not. So this is the pulmonary artery acceleration time or the time to peak velocity. Time to peak velocity is like this is done in the short axis view. You keep your Doppler gauge just below the pulmonary wall. So that you can get the pulmonary arterial flow. So whatever the tracing we get is the pulmonary arterial flow. So this time to peak velocity is, we take the time taken for the jet from the onset to its peak. The two lines which I am shown here. So from the onset to the peak of the jet, that is the time to peak velocity. Normally it will be somewhere around 100 milliseconds. But if it's less than 90 milliseconds, there might be some PAH component for that baby. And if it's less than 40 milliseconds, definitely there can be severe PAH. So when that time gets narrow, interval gets narrower, it means the baby is going for severe PAH. So that waveform will not be laminar jet, it won't be an envelope anymore. It will become triangle shaped. Next slide. Okay, I'll show the triangle shape in the coming slides. So the sixth parameter is the TPV with the RVET ratio. What is RVET? Right ventricular ejection time. So how do you calculate that? Same view, short axis view. Your Doppler get just below the pulmonary valve. You get the good pulmonary flow velocity. You calculate from time to start to the end. So that is the RVET. So you calculate this ratio. This is the least accurate measure of all the things we have discussed. It will be less than, anything less than 0.34 is abnormal. So normally it will be more than 0.3. If you want to quantify it, 0.3 to 0.2 is moderate, less than 0.2 will be severe. I have done for that baby. See, I have shown here. This I have taken from the textbook images. See, it becomes almost like a triangle. So your jet will be like this. It won't be anymore a laminar flow, and you can have a mid-systolic notch over here. That means your pulmonary flow becomes a W-shaped flow. So these are other indirect measures if the baby is having PPH or not. See, for this baby, see, it's almost like a triangle shape. This baby is having PA. It's almost a triangle shape, and we can suspect a mid-systolic knot, but I admit this is not a very good picture to show that. But definitely there is a triangle shaped flow across the in the pulmonary artery. Next. So with all these parameters, your TR velocity, your flow across the PDE, your flow across the PF4, your RV, your time to peak velocity, and TPV is to RV80. Once we are done with that, another thing which can help us is the intraventricular septal motion. Readings. See, how will we get this view? Short axis view. So everyone knows short axis view. Suppose this is a marker. Once we are in the short axis view, tilt the probe towards the, just tilt. Keep the probe there is and tilt towards the apex. Then we will be opening up the mitral valves first and then the papillary muscles. So just check for your septum at the level of the papillary muscles. So these are the papillary muscles. So you can see, you can appreciate that the septum is like your septum is straight. It's almost like a D-shaped left ventricle. Okay. Next. So what do you expect? So normal curvature, it's almost like a circle. See, those two are the papillary muscles. It's almost like a round configuration. When you have a flat septum, you can estimate your pressures are moderate. And when you have a crescentic septum, that means that septum is going into the left ventricle because of the significant right ventricular pressures. It's like a crescent shaped left ventricle. So there you can suspect severe pulmonary arterial hypertension. When quantification is there, we won't be going into that. So way to get your view, short axis view, tilt towards the apex, just above the papillary muscles. We need to visualize the papillary muscles properly, whether it's O-shaped, D-shaped or crescent-shaped. Next. So these are the basic parameters for assessing PPH. But as I have said earlier, in the pathophysiology, any baby with PPH can have a compromised cardiac function. Either it can be right ventricular, left ventricle. So always try to look your cardiac functions also while assessing a baby with PPH. So this Mohit sir have already dealt in detail. I'll just rush through. So what are your functions for your right ventricle? Systolic functions, visual inspection, that is the eyeball effect. Then your Taapsee sir again will be dealing. And this I'll tell you, right ventricular systolic with diastolic ratio and fractional area change, and RVO is already dealt in detail, so that we won't discuss. And what is the parameter for diastolic dysfunction? It is the E to A ratio. Next slide. So this is the eyeball effect. See, we can see we can appreciate that how contractility is good. So next. So Taapsee sir will take Tricuspid annular plane systolic excursion. Usually, remember it is 8 to 12. Anything less than 4 is significant. What do you do is you put your M mode along the lateral annulus. So once you get your apical four-chamber view, put an M mode along the lateral annulus. You will get a jet. So this is the measurement of topsy. So with this, we'll take a class. So I just rushing through. So anything less than 4 indicates there is severe dysfunction. So the third parameter, what I have told is the right ventricular systolic by diastolic ratio. So where you have TRJ, get your TRJ, then calculate what is the systolic divided by diastolic ratio. Systole is your TRJ interval. TRJ interval is your systole, and diastole is the interval between the two systole. So that if SD ratio is more than 1.3, remember there is a global right ventricular dysfunction. Next. So fractional area change again discussed. So get your apical four-chamber view in systole. Then in diastole, remember you need to get the full ventricle because this will be manual tracing of the endocardium. We will be showing in the workshop how to do that. So once we get the apical four-chamber view and refreeze it, this will be a manual tracing of the endocardium. So try to get the chambers right. So this we know the formula and we even know how to calculate. I'll skip. So in the diastolic also, apical four-chamber view, E and A waves. E wave is due to the passive filling of the ventricle, whereas A is due to the contraction. So usually it has to be equal. Both the waves have to be equal. If E wave is less, then you suspect mild. When it is more, that means your A wave is becoming high. That means it's more than 1.5, there is a moderate dysfunction. More than 2, there is severe dysfunction. Next. So left ventricular function, systolic again, visual, fractional shortening. We as neonatologists always rely on fractional shortening. We don't go into EF that much. And then myocardial performance index, and then LVOP. And for diastolic function, it is again E to A ratio and your pulmonary vein Doppler. So fractional shortening, everyone should be knowing this fractional, how to do this fractional shortening. We can do in two views, flask or the short axis view, long axis view or the short axis view. So once we get the long axis view, what do we do is, you put the M mode. That M mode has to be at the level where your mitral leaflets end. And in fact, in the image also, we should not accept even that much inclination. It has to be horizontal to the window. So it is very, as sir has already said, it's very preload and afterload dependent, and the normal is 25 to 40%. Ejection fraction, just remember you are doing the cube. Or whatever for fractional shortening, the same formula, you just do the cube. So normal is somewhere more than 50. So anything less than 30, we consider as 30 dysfunction, severe dysfunction. Again, LVO delt, so not dealing. Remember the chambers where you have to get that aortic VTI, apical four-chamber view, and aortic diameter. Again in the long axis view, where you are at the hinge of the. So there will be a lot of confusion whether way to measure your aortic diameter, that will be showing in the workshop. So it has to be at the hinge of your aortic valve. Next. So this myocardial performance index is a bit difficult to understand. I'll just simplify it. Once we are in our apical four-chamber view, we can keep the Doppler. I always do it separately because I find it very difficult to get a Doppler of both aorta and mitral valve at the same instant. So I do it separately. First I get the aortic VTI, and then I put my Doppler at the mitral valve and get my E and A waves. So just remember that B and A, and look at the formula. A minus B by B is your myocardial performance index. So your A is the interval between the two waveforms. I'm just simplifying it. Your interval between the two waveforms is your A, and B is the just your aortic VTA, that time. So your myocardial performance index is A minus B by B. So its normal is 0.25 to 0.38. It is independent heart rate and blood pressure. This we'll see when you're in the workshop also. Next. So diastolic dysfunction. So those are the E waves and A waves. Normal is 1:1. Anything more than 2 indicates severe dysfunction. Next. So another thing which can help in assess whether there is diastolic dysfunction is the pulmonary vein Doppler. Pulmonary vein Doppler, you have got two waveforms. If this velocity is less than 0.6, then that is significant. Then again there is, you have compromised diastolic function. Next. So that is what. So you first you clinically you have to suspect PAH. Once you suspect, get your echo, do your bedside echo, get your Diaget. Diaget not visible because of ventilation or high pressures or anything. Try to get RV inflow view. There also Diaget not visible if the baby has PDA. Calculate your pulmonary pressures using the shunt PDA shunt. Still even that is not possible. Still you are suspecting your PAH. I have told you your indirect measures of time to peak velocity and TPV is to RVAT ratio. And then your IV septum, interventricular septum. So then, remember, we need to see minimum of FS, left ventricular function, and right ventricular function, TAPSE. So, because our management is always pathophysiology based, so management is always pathophysiology based. Avoid hypoxemia and hyperoxia. Even hyperoxia is not good. It is PAH, get your 100% saturation. Even that is not good because even hyperoxia can cause free radical damage and even nitric oxide won't work properly. So the basics in management is lung recruitment, optimal PEEP, surfactant, gentle ventilation, and the next component is your support your heart. So for supporting this part again our echo helps. So as sir has discussed, whether we have to go for a vasodilator or we have to go for an inotrope, this we can assess only if you know the cardiac function along with our pulmonary arterial pressure. Next. So as we have discussed, get your Piaget, apical 4-chamber view. The PDA is there. Calculate your Piaget in using the shunt velocity. TPV in the short axis view. RVET is also in the short axis view. Interventricular septum short axis view with a tilt to the apex. And S is the cardiac function. And remember, always perform a comprehensive echocardiographic evaluation. As I said, try to get all the measures. Don't get satisfied like, okay, I have a Piaget, okay, I'm having PPHN. Always try to get all the components what we have discussed so that it will help us in managing the pH and also daily assessment. If the baby is not responding, we will be able to know why the baby is not responding. So how this functional echo helps as we have already discussed, timely diagnosis of PAH, rule out your cyanotic congenital heart disease before labeling it as only PPHN, and it helps in choice of the inotrope and it helps the monitoring the progress. That's it. Thank you.
Tracking or tissue Dopplers. Mainly we will focus on 3-chamber view and TAPSE. That is one thing you can do it easily. Then those other things are really advanced things. I will show you on the babies, but that is something which is a kind of really advanced practice in this thing. Okay, so we'll just start with a scenario. So this will give you a sense that how it will help you, even though we use our normal parameters, why they are not helping us and how they will help us. So this is a term baby born to by normal 3.2 kg male. ABGARs are good. NICU on CPAP, then on ventilator, conventional with seizures. Echo was done, showed moderate PPHN, was started on milrinol, sildenafil, and on Lasix. This was the things which were done in that baby. Okay, PIP was 28, PEEP of 6, F5 of 100%, and this was the pH. You can see the pH, it is acidotic, isn't it? Acidotic pH. Bicarb is 8, base def is minus 20. OI is 28, and this is the blood pressures. Blood pressures are okay. This is that baby on very high ventilatory settings. Okay, this is the one with IBP and all that thing which has been going on. So these are the vitals for that baby on very high conventional ventilatory parameters. Okay. So the issues what are the issues in this baby? What is the issue?
Respiratory failure.
Respiratory failure, isn't it? You agree with this? So oxygenation and hypotension is an issue with this baby. So what you want to do? What you want to do?
Increase the oxygenation. First, increase the oxygenation by increasing the MAP. Yeah. Pneumothorax. Yes.
Okay, so there was a bad PPHN. What need to in functional echo? This is what we need to do, isn't it? What to see that what is the severity of pulmonary hypertension, how are the RV functions, and afterload to the RV is your pulmonary pressures, isn't it? You have to assess that. You have to decrease to improve your RV functions. Preload, and it is again I have already discussed preload to LALV. Then again have to assess LV functions. You have to assess LV afterload. Okay, so this was an echo. Anybody can just describe which view and what is happening in this heart?
Apical four chamber view. Left side is like
So it is RARV is dilated. Yes. So you can see which is RARV is dilated and contraction is low. Both is decreased on RV and LV. Both contractions are low. And this is the TR jet estimation. But if your RV is failed, then TR jet estimations are not reliable. Okay. So estimated pressures from this is 50 plus 56. Okay. So LV functions, okay, we need to do by fraction shortening. This we have already discussed. And then LVO, we have already discussed. So this was the findings. Blood pressure 52 by 32, 38. LVO is 132. It is normal or decrease? We have discussed that in last lecture. So it is on the lower side, isn't it? FS is 39% normal, normal, isn't it? CFT is prolonged, and pH you can see again is acidotic. So the issues after knowing the functional echo findings. Oxygenation is an issue because of pulmonary hypertension. RV dysfunction is there, so TR jet is not reliable. Blood pressures, okay, but they are not reliable, even though the numbers, if you see 38 mean, is okay. But clinically, the baby is in low cardiac output state. Why? Because there is LV dysfunction and there may be increase afterload after. Because as we discussed, the SVR may be high. So these are the issues. So it clearly tells me that whatever numbers vitals I am getting, and whatever functional echo normal parameters I am getting is not at all giving me a very good picture of what is happening to this baby. है ना? अभी तक, whatever we have done. So it is not giving very good this thing. So this is something like, you follow one parameters. So this is nothing but a conventional functional echo parameters, and you have been following it. Since long you have been doing it. But then you get to see the problem in that. There is a problem. Okay, so that problem we need to solve somehow. Somehow we need to think out of box. Okay, so that is very important. And with whatever commodities, whatever facilities you have, you need to think out of box. So if you think out of box, only then you will be able to achieve the final goal. So you need additional parameters to know your RV functions. Okay, that is one thing. So the best way is to TAPSE. TAPSE is nothing but a tricuspid annular plane systolic excursion. This is a full form. It is nothing. What happens is heart contracts like this also. So what we are doing is where the tricuspid valve is attached to the RV valve, we are calculating the movement, that how much it has moved. So that movement will tell me how much it has contracted. This is what I am doing. It can be done by M mode, normal, or by tissue Dopplers, two-way. But basically, it is doing the same. And we can do in both this thing here. So we can do it in the lateral wall here and in the medially towards the septum, so that I can know the movement of both sides. Why it is being done in both the ways? Because basically this parameter and everything is been done in adults. In adults, you get MI, myocardial infarction. So that affects the selective part of the wall. That does not happens in newborn, but this is what we have extrapolated from the adults. Okay, so they do TAPSE in the towards the septal side and towards the wall, lateral wall side. Okay, so when you do this, so basically your M mode passes through this and it records the movement, that how much that is in systole it will come down, in diastole it will move up. So how much it has moved. Okay, this is in normal 2D with your M mode, and this is actually it is in tissue Dopplers. Basically tissue Doppler is nothing. What tissue Doppler does, the normal blood Dopplers you do, isn't it? So what we are doing catching the velocity of RBCs. Here, similarly, the tissues also break up in the wall. So they also move. So what you are doing is, machine is catching the movement of the tissues, Dopplers of the tissues it is doing. So that is why it is known as tissue Doppler. Why this tissue Doppler is in calculating tab? It will give you the same results. Why it is better than this? Because here the movement, here the movement of blood is similar as blue and red, but here you don't know where is to put the cutoff. Here you can clearly know the where to put the cutoff. Here where this blue and red bifurcates, that is a point I need to calculate. So the perfection is better in tissue Doppler colored tissue Doppler mode as compared to M mode. That's the only difference, nothing much. There are further details, I don't want to go into that, but the crux of this is this gives you a better cutoff line to put your marker if it is in color tissue Doppler, it is red and blue, instead of just 2D black and white. Okay, so this is where you need to do it. So this is how you do it in black and white. Why I'm not showing the tissue Doppler in this? Because most of the machines what you will be using will not have tissue Dopplers, but it doesn't mean that you cannot do your TAPSE. You can very well do TAPSE by this, just by inverted 4-chamber view. You bring this lateral part of your wall of RV into picture, hit M mode and cross this, where this node is there, where this tricuspid valve join the lateral valve, you put the line through across that, and then hit M mode. It will give you something like this. And then you can calculate what is the difference between this point to this point, and that is your TAPSE. Okay, this ratio, I will skip the ratio. Okay, so TAPSE normal in term babies it is Some people say it should be more than 8, but the range is 6 to 9. In preterm, it is 6 to 7. But in preterm, if it is less than 4, it is bad. In term babies, if it is less than 6, it is dysfunction, TAPSY. Okay. This again is, what is this? Apical 4-chamber view. And what parameter we are trying to do in this? Ejection fraction by Simpson's method, isn't it? So similarly, you can talk like, why can't we do the ejection fraction of right ventricle? But we have discussed the shape is not proper, okay, in apical 4-chamber. But we can catch that posterior wing of your RV by doing 3-chamber view. In 3-chamber, you will get the almost 70 to 80% of RV volume. Okay. This is your anterior chamber, anterior part of your RV, and this part where it goes back is the posterior part. That's why your RV is doing EF in a apical 4-chamber view is not reliable. Okay. So that's why we do this 3-chamber view. This is 3-chamber view. In this, you will see the posterior part of the RV and the inferior and anterior part, the whole thing. So this, by tracing this, you can do the EF in this 3-chamber view. How to do the 3-chamber view? You can do it in through 2 ways. So this is a 3-chamber view I'm doing in the same baby we are discussing. So in this, one is where you do the short axis view. Okay, the parasternal short axis view. Similarly, you put the probe there and try to rotate it anti-clockwise. From 1 o'clock, you try to bring it towards the 12 o'clock position. Okay, and you will get 3-chamber view. Okay, or apical, from apex, you try to go towards the 2-chamber view. So again, it is from 3 o'clock, you need to rotate anti-clockwise and bring the probe towards 11 to 12 o'clock position. And you will get 3-chamber view. So this is again, that one I was showing in apical 4-chamber modified, and this is parasternal short axis modified. So instead, from 1 o'clock, okay, you have to bring a bit anti-clockwise, you have to rotate and sweep up, bit upward. Okay, you will get 3-chamber view. We'll show you on the station. It is similar, like places as windows is same. You just have to rotate anti-clockwise and sweep up. You will get 3-chamber view. So this is how you will trace, again, in end diastole and end systole, big and small. In that, you will have 2 valves involved in this. So this is one is your tricuspid and one is your pulmonary artery valve. So those 2 have to be closed if you're tracing the area. Your tricuspid valve and pulmonary artery valve both should be closed. This is how it will look like. Again, in parasternal short axis, this probe orientation marker is up, but in this 3-chamber view, it is down here. Okay, this thing you need to keep in mind. Okay, so this we have discussed, everything we have discussed. I will skip all this. Isn't it? We have discussed everything. I will skip all this. This also we have discussed. So this slide just shows you that sometimes you observe that LV is dysfunction, RV is normal, or RV is dysfunction, LV is normal. But eventually, if one ventricle is affected, is going to affect the other ventricle. After 2 hours or 3 hours, your RV function decreased will lead to our LV functions decreased. So that is very important. That's why you need to act fast. One will lead to other. Tissue Doppler imaging, I've just discussed with you. This is basically, this video is showing that the heart is majorly formed of 3 types of fibers. One is longitudinal, one is cross-sectional, and one is circumferential. Circumferential is like this, cross-sectional is like this, longitudinal is like this. So this is what it is showing. This video is showing. Basically showing the same. So different part of the hearts is being formed by muscles at different angles. Why you need to know? Because again, when you do the Dopplers of the blood, you need to know the direction of the flow of the blood. Similarly, for tissue Dopplers, you need to know the direction of the muscle fibers. That's the only thing. That's how you relate it. Okay, and that's how the tissue, when you put in 2D apical four chamber, put a tissue Doppler, this is how your heart will look like. It will look red and blue. Again, see, when your RV is contracting, your this is your heart, this is where your probe is. If your RV is contracting, your blood from RV is going out through pulmonary artery. So it is moving away from the probe. So it will look blue. So suppose if I am doing tissue Doppler, if my muscles are contracting like this, probe is here. So while contraction, the movement of the tissue fibers will be downwards, isn't it? So it will be towards the probe. So it will be red. So the movement of your tissues will be opposite to the movement of your blood. If your blood looks blue in the Dopplers, in that your tissue Doppler, your tissue movement will look red. So that's why, see, this is, I don't know, in PDA, they must have shown you the mitral valve Dopplers. In that, you had EA ratio and IVRT to measure. So this is nothing. This is basically inflow of mitral valve and this is outflow. But here it is ulta. The inflow is down. This should have been up when we do the blood Dopplers. But in tissue Doppler it is same. EA dash, what we call this is E dash A dash. And IVRT is up. Why? Because the movement of the tissues are always opposite to the movement of the blood. Okay. And when we do the Dopplers in the mitral wall, in blood Dopplers, it is not possible to calculate IVCT, that is isovolumetric contraction time. We always say we ignore it because we don't have the measures in the machine to measure that. But in tissue Dopplers, we can measure that. So it can again give you additional information. So that is a benefit of this. Okay, then how to significantly judge what is A dash, C dash, IVRT? It is very much similar to what we do it in the blood, but the parameters and graphs are different. Okay, so this is something you need to do once you are very well versed with all the normal parameters of the echo. But this is just to give you an idea. This is how it will come in the machine. So why it is important? Because it gives you like which part of the right ventricle is dysfunction, medial part or lateral part. So that gives a lot of information. Okay. So this is how for longitudinal you do it when the heart is being cut longitudinally. And this is then you do it in two parts because major is longitudinal muscle fibers and circumferential. So you do it in longitudinal and circumferential is like this in parasternal short axis. So this is parasternal short axis, papillary muscle view. So this is what is showing. These are the caustic windows. So this is longitudinal movement of the tissues. It divides the wall into different sections because in adult you need to know which artery has been blocked. So the section which is affected, that artery is blocked. Okay, this is how it will look like. Just by seeing, see now, movement is, contraction is low. Just by seeing the amount of redness going up and down, you can judge. So just by seeing it, it is no more subjective, it is objective now. See this. It will come in the cross-sectional also. This is radial. See, can you see the redness and movement is very normal. And this is abnormal. Can you see? Just by seeing the color, intensity and movement, you can stat away, you can judge, okay, this is not normal. Okay, and just, it will show you, this is a normal circumference. It will show you, see, this part of the septum is affected, isn't it? The movement here is very abnormal, decreased, rest is normal. So just by seeing the color and the movement, you can judge that which part of the septum is affected. So that's what additional information you will get to see in this. Okay, so there is another what we say as blood speckle imaging. You can see this. This is a normal flow of the blood, and this is in PDA. You can see LALV is dilated in this. This is HSPDA. And this is LALV dilated. But did you see the amount of color blood which was flowing? आपने कुछ नोट किया? मैं दोबारा चलाता हूँ. Amount of blood देखिए, right side वाले में and left side, red and blue. The amount of blood are you able to appreciate? But in normal color Dopplers, you are not able to appreciate the amount of blood which was flowing through the mitral valve. by doing the speckle, you can even just see the amount of blood which is flowing through across it, just without doing any readings. What the speckle tracking is doing, there, the whole flow of the blood RBCs is look as red. It marks the RBCs. It speckle track them. The speckle is nothing but choti chingariyan, small speckles. It picks up all the RBCs. So it will give you the amount of RBCs in that area. So that's why it looks like this. So this baby then ended up on nitric oxide. So this baby and on high frequency. You can see this baby is on high frequency on nitric oxide with MAP of 26. Okay. And now it started maintaining saturations. So was severe PPHN with shock. So started maintaining saturations on this parameters. Now as SpO2, which was in 90, has gone up to 97. Okay. So TAPC, which was been done, was 6. So term baby, 6 less than 6 is bad. So TAPC showed that there was RV dysfunction. That's why the TR jet was not reliable. Fine. So then what else? That clearly showed there is RV dysfunction, and then it's a severe PPHN. So if it is RV dysfunction, severe PPHN, we need to start some pulmonary vasodilators, and that's why we started with the nitric oxide. So what else? Now there is a severe pulmonary hypertension, and RV is dysfunction. What else we need to look in this to treat this way? What else we need to look into this? Okay, RV dysfunction is there. There was metabolic, there is a low cardiac output state. So our LV dysfunction will be there. But I'm just now concentrating on RV. What else I should do to relieve this RV? One, I have put this baby on high frequency. I've started nitric oxide. What else I can do to relieve RV dysfunction? Okay. So need some vent out, isn't it? Because my RV ka afterload is pulmonary hypertension. I'm trying to relieve that. So what I need to do is I need to look for PDA, whether it is open or not. Sometimes if there is severe PPHN and RV dysfunction is there and babies are not improving as you want, you start prostaglandins. So what happens with the prostaglandins? One, it is a pulmonary vasodilator and it acts through the different route as from where the nitric oxide is working. Two, it gives you a vent of valve for the RV. Through PDA, the blood is shunted out. So hence your RV dysfunction improves and your baby improves. So I have to look for PDA, whether it is open or not. If closed, then we have discussed, we have to start with the prostaglandins. In babies, we do it. So PDA, when we did, was open, was 4 millimeter. So we need not start with the prostaglandin. And it was shunting 70%. It was bidirection shunting, but majority it was shunting right to left. So that also showed that is a severe pulmonary hypertension, isn't it? So we started with the vasopressin. Okay, as mean blood pressure went down from 38 to 31, we hold sildenafil, which the baby was on. Milrinone was started. Speckle tracking was been done. Okay. What this thing tells, I won't go into it. Strain rate decrease, velocity maintained. There are two things we do on speckle tracking. One is strain rate, and then we strain velocity. This one differentiates whether your myocardium is weak or your afterload is high. Okay, if your strain rate does not change, okay, if your afterload to LV if afterload to LV was not an issue, means if your strain rate remains same, does not change, that means your afterload is high. Okay, if your strain rate changes, it decreases, it means afterload is not a problem, your myocardium is a problem. And why the myocardium is a problem in this? Because this baby is hypoxic, OI was very high. Number two was acidotic. So your myocardium contractility was been affected. So if in this baby, what I need inotropic agent, not a vasodilator agent. My afterload is not, I was not able to get that information from a normal echo. Now I know my afterload is not a problem. The problem is my myocardium. So I need something to augment my myocardium. I don't need something which to decrease my afterload. Clear? So dopamine is not a good, dobutamine will be bad because it is not very strong inotropic agent. It causes vasodilatation. I don't need vasodilatation. I need something which is very good inotropic agent, which increases the contractility of my heart without touching my afterload. Milrinone can be thing, but if your blood pressures are low, it is not a good idea to start with this thing. My epinephrine will be a good will be a good drug to start in this baby. And now it has been documented that low dose epinephrine is a pulmonary vasodilator. We use very oftenly epinephrine in shock babies with PPHN. Norepinephrine is again dilator in low dose, but it's not inotropic agent, it's a vasopressor. So I don't need to have any vasopressor or vasodilator. I need inotropy. I need to maintain calcium. I need to have a good thing which contracts my heart well. So that was the only thing which I told. You calculate your blood pressures and then you see, but other thing is VCF, circumferential shortening. That is one thing you can do. Yeah, I haven't taught because there will be too many things for you, because I am skipping all, because these are things which are very advanced things. Once you are not used to these things, it will be bad for you. You won't even remember this. So, like in this case, this was useful to us, isn't it? TAPSE was useful because we were able to decide on whether we need to start in indomethacin or not. Oh, sorry, not indomethacin, prostaglandins or not. And then this was useful because this baby oxygenation improved, but there was an issue with my perfusion and cardiac output. So I was not able to make whether your contractility is because of myocardium or my afterload is high. And I've already started vasopressin in this baby, isn't it? So if that is high, I need to know if my afterload is high, then I need to stop my vasopressin. But this speckle tracking clearly showed me that afterload is not high. It is not because of afterload. It is because of myocardium. So that gave me the indication. Now I need to start with epinephrine. Got my point? Yes. It got, but in higher doses. Like higher doses, I would say we start with 0.05, but when it crosses 0.2, then its alpha action is very pronounced. Till that, its alpha action is not very pronounced. Less than 0.2, yes. But from 0.1 to 0.2, its inotropic agent action will be good. So its effect on beta receptors will be good. We always start because we have already on vasopressin, so we always start with 0.05 and then we titrate up, but we tend not to go more than 0.5 because then the vasopressor action and then in that time, that dose, it will be pulmonary vasoconstrictor also. So whatever you have achieved in oxygenation, that will also you will lose. Exactly, we don't have studies for that. We don't know how to follow that, but there are studies in pediatric and adults. But newborns, we don't have much of the studies to have clear cut that at what dose, how much will be the effect on, but that will be something good to do. Okay, so this is what we did. We started with epinephrine and we stopped milrinone. Why we stopped milrinone? Because the blood pressure was coming down and it decreases your diastolic blood pressures, milrinone. And then eventually, as sir told, we had to start with the NORAD. Okay, but for that, why we started with the NORAD? Because vasopressin always started, but the main issue with the vasopressin is it decreases your urine output and baby becomes very much bloated. Okay, so we had to stop vasopressin and switched over to NORAD for that action. Okay, so this is how, this is just a case to show you that your conventional echoes gave you some information, but there was some additional information we needed to know. This is how we get it from TAPSE and from speckle tracking or tissue Dopplers. so then again the thing comes, where the TAPSE is being now very commonly used because it is reproducible. The variation is less, it is reproducible. So that's why it is a good parameter to use, very easy to learn. But, and even the 3-chamber view, but TDI and speckle tracking, the reproducibility in newborns is still not much. It is still a study parameter. So that's why I took it, speckle tracking in PDA, HSPDA, I took it as my topic for thesis. So let's see what I will get. So my friends, this is the same baby. We started initially on conventional ventilator with Milrin on, but we could not achieve the desired results. So what we did, we started this baby on vasopressin. Okay, but again the vasopressin, we had any issues with this baby. So what we did, we started with the nitric oxide and high frequency. We achieved something, but so in the end the baby crashed. So that's, we started doing speckle tracking and we started doing TAPSE. So we had to bring in our new machine. So that new machine is arriving. So we did that. So we got the results what I was talking about. So that person arrived with the new machine. So we were all set to go. But after treating and doing speckle tracking and everything, that baby ended up on the deathbed. The baby died. So the lesson from this presentation is, you should be knowing everything, try everything, but that is not a guarantee that you will be able to save the baby. Okay? But yes, that was your target. You did it. You tried. Thank you very much.
Thank you, sir. No, thanks for your excellent contribution as usual and as expected. So now we'll take the short lunch break. Shall we meet up again in half an hour time, if that is okay? Now it's already 2:12, so we'll meet up here at 2:45 p.m. sharp. Thank you.
Poor grade 2 murmur. Blood pressure is not recordable. SpO2 pre-ductal is 69%. Post-ductal is unrecordable. Clear? On examination, mottled, poor pulses, cyanosed and gasping. Clear? So what you will do? So if this baby, like in last 10-11 years, I have seen at least 3 to 4 times I have seen such baby in my OPDs. That we had to pick this baby and run in ICU. Great. Okay. So that's good. The first thing you should do, without thinking of anything, you have to do resuscitation. That is most important. It may be cardiac, may not be cardiac, but you have to do the resuscitation irrespective of whatever may be the cause. Fine. Then sir told to do the functional echo. Before functional echo, should we do the basic tests first and then go for echo? Yes. So this is X-ray chest of that baby. Cardiomegaly is there. Okay, fine. Okay, like mild cardiac congestion is there. Cardiac congestion is there. Lungs are congested. Good. Yes. Pardon? Yeah. So the base, at the base, the eyelid shadow is broad, but that can be because of the thymus. Okay, fine. Okay. So in the vitals, did you notice anything in the vitals? Yeah. So there was the postductal is unrecordable, and preductal is around 70%. So does that give you some hint? Because see, I would say the sir would agree with me. Without an echo, even many of the congenital heart diseases, clinically 90% you can diagnose without doing an echo. Like the seniors used to do it. Now we have echo at hand. That is something else, but they used to do it just on the basis of X-ray chest and ECG. you can diagnose clinical X-ray chest ECG. 90% of the diagnosis you can make. Now we have SpO2 monitors also. That is something which is very good. So pre-ductal and post-ductal is difference is there. What does that indicate?
और मैं क्या करेगा
So he is selling cooptation of aorta.
ಇಟ್ಬಿಡು ಹಾಕು ನೀನು ಹಾಕು ಹಂಗೆ ನೀನು ಹಾಕು
Good. So your pre and post-ductal thing that shows that the system which is using your upper right side, upper part
ಗೊತ್ತಾ
is being supplied with oxygenated blood and the rest of the part is being supplied with mixed blood. Something is happening there. So this is the most common site at which it happens, mixing, and that deoxygenated blood goes from right to left shunting. This is the most common extracardiac site where it happens. PDA. Okay. So either it is very severe PPHN or it is duct dependent systemic lesion. See, duct dependent can be two types. It can be right sided lesion, which is your pulmonary circulation is duct dependent, and then it can be left sided, in which your systemic circulation is duct dependent. If your systemic circulation is duct dependent and your PDA becomes small or close, how the baby will present? Baby presents with shock. Its presenting thing will be shock. And if your pulmonary circulation is duct dependent and your duct is closing, how the baby will present? Cyanosis, respiratory distress, isn't it? So this baby presented with what? Shock. Okay, and there is a pre-ductal and post-ductal saturation difference. Most likely, there can be a cardiac lesion, and that too is duct dependent and is left-sided obstructive lesion. Okay, fine. So what will be the option A, B, C, D out of this? See, in this, baby has presented to you in shock. So this right-sided outflow obstructive lesion is ruled out. What is left is hypoplastic left heart is again duct-dependent left-sided systemic lesion. Critical coarctation of aorta, what he has told, again is a duct-dependent left-sided obstructive lesion. And one is left outflow obstructive. So which is a broader term? Left outflow obstructive. So from a clinical point of view, what we can say is it is a duct-dependent lesion, which is left outflow obstructive lesion. We don't know whether it is hypoplastic left heart. We don't know whether it is severe coarctation, critical coarctation of aorta. We don't know whether it is aortic stenosis. We don't know whether it is interrupted aortic arch, because that diagnosis has to be made by echo. Okay, but clinically, we know that this is duct dependent lesion, which is left sided systemic perfusion is dependent on the duct. Okay, so if I'm not getting an echo done, does that stop me from treating this baby? When I ventilate, I have put this baby on the ventilator. Okay, I have started with the bolus, I've started with the inotrope. But what is the drug I need here? Prostaglandins, isn't it? So, echo, if I'm not getting an echo done, it is not going to stop me from starting the prostaglandin because my baby is already on ventilator. Fine. What are the side effects of prostaglandin? Major side effect is respiratory depression. The baby is already on the ventilator. You have the facility of the ventilator. The only thing you need to do is you have to start with the prostaglandin and then get an echo done. At the max, what will happen? Your cardiac anatomy will be normal. You have to stop the prostaglandin. At the max, you have to do this. Nothing else, isn't it? But clinically, you have made the diagnosis that this is left outflow obstructive lesion. There is something which is duct dependent and it is of the left side. Fine. Is it? But now it is very commonly available everywhere. Most of, like in Gujarat also, it is available everywhere. See, if you are suspecting, this is just a point. If you are suspecting duct dependent lesion, it may be right or left, whatever. If you are suspecting, see, we have few clinical things we need to do in all the babies. One, preductal postductal saturation, blood pressures in all the forelimb. Okay, forelimb blood pressures, preductal postductal saturation, and then if you want to move a bit ahead, whether to diagnose it's a cyanotic or it's a severe PPH or a ASNH, you can do hyperoxia. But nowadays the echo is so handily available that instead of doing hyperoxia test and doing the breaking the head over that, you can directly ask for an echo. So now we have stopped doing hyperoxia test in our units. Okay. Previously, we used to do that. Yes, people used to do even the after hyperoxia test. You have next step is to differentiate further severe PPH and with cyanotic heart disease is hyperventilation test. Okay. So, but now everybody knows that CO2's level less than 35 for more than 30 minutes or 1 hour is detrimental for the white matter injury in the brain. So that's why we have stopped doing it altogether. Okay. And third point which we need to learn and put it in our head is anytime you are suspecting congenital heart disease which is duct dependent, don't hesitate to start the prostaglandin. That is very important. So this is one case we normally see, many times we have seen in our waiting area in OPD, or parents bringing the, like, most commonly when the babies are being brought, this is my personal, I have seen many times the babies have been admitted and they are brought from home with aspiration. History will be aspirate, baby aspirate karke and done. But whenever I have done an echo for that baby, if they are alive, in 80% of those babies I have found some congenital heart disease or something else. 80 times there is reason for babies to have SIDS, die. And always it is being labeled as aspiration syndrome. Aspiration syndrome. Aspiration is not that. Term baby taking breastfeeds, why the hell the baby will aspirate? It should not. Nature does not allow that. There has to be some reason for it. But mostly by the time baby comes, the baby is almost done. So that's why we are not able to find the reason. But whatever babies I have done echo, even though the baby had died, but just, at the time, at the nick, when the baby is just gone and this thing, I have done echo. Twice or thrice I have found it's critical coarctation of aorta. Once I have found it is hypoplastic left heart. Because in India still undiagnosed, antenatal undiagnosed cases are, even though they are less, but they are still quite a big number still. Okay, so I will discuss one more case, then sir will discuss. So this is another case. Again, term baby, male, birth weight of 3.6 kgs, born to gravida 2 para 1, born by normal general delivery, cried immediately after birth, discharged home. Okay. On day 3rd of life, admitted with lethargy and refusal to feed. Clear? Was admitted in some peripheral NICU, was started on oxygen and IV antibiotics. Most common diagnosis is sepsis, isn't it? Very typical. But baby started having labored breathing there, was shifted to level 3 for further care. By the time this baby was shifted to level 3 NICU, the baby was on ventilator, okay, with very high pressures on ventilator, FiO2 of 100%. Still mottled, DIC and bleeding with lot of edema, third spacing. Very typical of sepsis with DIC, isn't it? So that was the scenario. This baby was like that. Heart rate was 140 and saturations 78%. Is it okay to just write saturation 78% or you want some particular reacted? But yes, preductal and postductal. And see, preductal 100% is always which hand? Right hand. Is it the left hand is preductal? 50%. So there was a big, now the thing is, if you do echo for the whole population in the world, 96% of the people left hand will be preductal, 4% of the population in the world is having left hand as a postductal. So your left hand is not always preductal. So 100% is always right hand, and the postductal is always lower limbs, not left hand. So you just have to keep this in mind. Okay, fine. So I should have mentioned SpO2 78% right hand or left foot or whatever. Clear? Fine. IBP. So in our see in neonatology, I don't know what, but NIBP is useless. It's of no use. Like from last 4 years, we have not used even a cuff of blood pressure in our only some an infant comes with the renal nephrologist reference, they send us for blood pressure measurement. We don't use NIBP at all. It's a totalless use. Like I have seen babies, dead babies, and blood pressure showing normal on dead babies. So it is of no use. If you want to use something in sick babies, it has to be IBP. So this is one thing, because the sensitivity and specificity of NIBP is just 20 to 30%, not more than that. It is proven, very well proven. Okay. So this is IBP 32 to 24. Like by all standard, it is less. It's hypotension in baby in term baby. CFT is prolonged 6 seconds. Pulses are poor in all the 4 limbs. Okay. So everybody agrees this hemodynamically this baby is very bad, isn't it? So how you will manage it? So this baby is septic shock, DIC, on very high ventilatory settings. Still the baby's blood pressures are very low. So what you will do? Start from here. I will ask everyone.
We give fluid bolus and then start baby on inotrope.
So give fluid bolus, start baby on inotrope. 1 point. What else?
Same, sir. IV normal saline bolus, then inotropes. Okay.
Anybody? Anything different from this?
Ventilated blood glucose and investigations.
And ventilation.
Sir, ventilation और catecholamines में और बस.
So catecholamines you means to want to address the steroids, is it? You want to give steroids. Okay.
इसको तो पहले ventilation पर लेना होगा सर. SpO2 है. अच्छा, ओके, ठीक है. तब बोलस दे दिया, आइनोट्रॉप्स लगाए, एंड देन फिर डायग्नोसिस में चलेंगे क्या कितना सैचुरेशन बढ़ा या नहीं बढ़ा, कितना परसेंटेज. सैचुरेशन अगर नहीं बढ़ रहा है तो क्रिटिकल साइनेटिक हार्ट डिजीज हो सकता है, एंड देन अकॉर्डिंगली मैनेज. प्रोस्टाग्लैंडिन है.
Okay, so what he has just uttered is, one, it may be a congenital heart disease, what he is just saying. Okay, so maybe duct dependent. Okay, fine. So see,
we can do an echo and assess the hemodynamic status, and accordingly we can decide whether bolus or inotropes, which inotrope, whether pressors, what is required.
We'll come to that. So you want to share something on this? So the first and foremost thing, you see, this baby is sick on very high ventilatory settings. The first thing, as a clinician, what I would do is, any baby on high positive pressure ventilation and baby is not maintaining blood pressures or very badly perfused. So what mnemonic we follow? DOPE, isn't it? So first of all, I would like to do an X-ray chest or cold light to rule out pneumothorax, isn't it? Because if the pneumothorax is there, it will explain everything. The baby is not maintaining perfusion saturation. The baby is not maintaining oxygenation. That can very well tell you. So I can just share, like there was a baby in my unit, was having some issues, was on ventilator, okay? I went home and previously, that was a time when I stopped teaching echo to all my neonatal fellows in the unit. I received a call from a fellow, sir, this baby is having very severe pulmonary hypertension. I was totally confused. Like I just took the rounds in the evening and the baby, we were weaning and the baby was supposed to be extubated tomorrow. Tomorrow we were planning to extubate. And now he's telling that his baby is, I asked him, why the hell you have done the echo for that baby? That baby is on weaning mode. Like stabilized, everything is well. And why you did echo? He told, sir, the baby was not maintaining saturation. I told, if the baby is not maintaining saturation, then what is the X-ray? He told, sir, X-ray aane mein time tha X-ray, so I started doing an echo. On echo, what he found was there is high pulmonary pressures. Basically, he didn't do even the cold test. We have everything in the unit. Instead of doing cold light test or asking for that, concentrating on that, he directly went into the heart, and he missed pneumothorax. And that baby was having pneumothorax. हो जाता है ना, लेकिन one thing is, हम अल्ट्रासाउंड के पीछे इतना ज़्यादा we put our head that we miss all those things. So the simplest thing is, do cold light test, get an X-ray chest done. First rule out dope. After ruling out dope, then only you go ahead. Fine. So that is the first learning lesson. That never miss your pneumothoraxes. Never miss your X-ray chest, cold light, or if you are trained in lung ultrasound, very good. Go ahead and do it. Clear? So that is the one thing. Next thing, as everybody was talking, that was ruled out, dope was ruled out. Fine. We gave normal saline bolus. And this baby already must have received so many boluses because that baby was almost of the size of that open care. The whole open care was filled with the baby. He was so much bloated. Fine. And this baby, when we received, we gave bolus and was already on dopamine, dobutamine, vasopressin, and adrenaline. 4 inotropes were going on. Fine. And this was the BP on 4 inotropes. So what next? What can be the issue now? Now your two wishes are fulfilled. We have ruled out dope. We have ruled out pneumothorax. So pneumothorax is not there. Fine. Already given bolus and already on 4 inotropic sport with this much of blood pressure.
Pericardial
can be there. The baby may be having a tamponade. So the next thing is functional echo, isn't it? To rule out pericardial effusion. Okay, one. Then other thing we need to rule out, because this baby is on very high ventilatory pressures. Okay, so if your PIPs are so high, so lung is hyperexpanded. What the hyperexpansion of the chest will do? Yes, that will be compressed. One, venous return will be affected. Your preload will not come into the cardiac. It's what the heart will pump out. Okay, okay. So one, you can rule it out by doing an X-ray chest. Rib spaces you will count. Okay, see the position of the diaphragm. Okay, the next thing what you will do is you do subcostal view. For what? For what you will do the subcostal view? You have done an echo. Contraction seems to be okay. Okay, so this is a clip. You explain this clip. What is this? What is this view and what is this?
This is subcostal view, longitudinal view. Looking at IVC draining into the right atrium. IVC, yeah. Right atrium. It is collapsible.
In NICU, this was the conventional ventilator settings. PIP 22, PEEP of 5, RR 40, I time 3.3, and FiO2 of 100%. So this is bad, isn't it? Moderately high ventilatory settings with 100% FiO2. This is the vitals. Heart rate 184, tachycardia is there. This is IBP, 44, 20, 28, mean of 32. Is it normal, high, low? So this is low blood pressures. So now if I talk about blood pressures, our general notion is we always take mean blood pressure and that is equivalent to gestational age, isn't it? You know how this number come up?
From where this number came? 6 neonatologists sit in a beer bar.
This is very interesting. There's a published paper on this. The blood pressure, mean blood pressure equivalent to gestational age was in early 1900. 12 of the pediatrician, only one was a neonatologist in England, London. They went to a bar, they were sitting there, and they were discussing that we don't have any numbers for blood pressure in newborns. So they came up there with a number that the gestational age is equivalent to mean blood pressures. And they published the paper. And since then, we are following the same thing. There is no scientific data behind it. And now it has been very clearly said in the published papers that whenever we talk about blood pressures, it has to be individually talked. Systolic, diastolic, and mean. You should not be just talking about. But in this, all the three blood pressures are lower than the third percentile of all the, like now we have normograms for blood pressures in newborns with gestation and day of life. Okay? If at that particular gestation and day of life, systolic blood pressure, diastolic blood pressure, and mean blood pressure are lower than the third percentile, then the baby is hypotensive. Clear? Fine. So CFT is prolonged, and this is preductal is 85 and post is 86. So almost same. Is it? Isn't it? Fine. With high ventilatory settings, there is no difference in pre and post ductal. Okay. CFT is prolonged. Fine. So their labile saturation fluctuating. So what will be your action in this baby? So one is meconium aspiration is there. Meconium history is there. Baby is on high ventilatory settings. So we are suspecting PPHN. One. Fine. So what you will do? Okay. So he wants to put the baby on HFOV. You want to go do something else? Okay. So one, he wants to do an X-ray chest to look for the inflation of the chest. He wants to put it on the high frequency. He's telling to put on the nitric oxide. Okay, fine. So we will take his step first. Surfactant. Okay, fine. Great. So now, whatever we are talking about how to manage PPHN, isn't it? So one is lung recruitment should be proper. Fine. Yes. So we have to first manage the respiratory issues. Okay, lung recruitment, respiratory issues. If we will manage that, only then we can go ahead and manage the PPHN. Fine. And then we will talk about PPHN and shock. Fine. So next section, as he told, what we'll do is X-ray chest to rule out pneumothorax and see the inflation. HFOV, surfactant, yes. Then echo to see how much, if the PPHN is there, we have to quantify the PPHN, isn't it? To see the functioning of this. And then decide about nitric oxide. Before deciding about nitric oxide, we can go ahead and take the option of surfactant. which we should do before? Nitric oxide we should start and then do surfactant, or give surfactant and then start nitric oxide? Why? Because until unless you recruit your lung, your nitric oxide will not act. For nitric oxide to act properly, you have well recruited, you should have well recruited lungs. Fine? Great. Good. So this is X-ray chest of that baby. So anybody can describe X-ray, what is there in the X-ray? Okay, so that is meconium aspiration syndrome. So that is very typical of meconium aspiration syndrome. Fine. Expansion is fine because in meconium aspiration, most of the time, your expansion will be okay. It will not be bad. Air trapping. So there can be a hyperinflation, but with just air trapping, you won't have a hyperinflated lungs. Okay, but yes, this is typical MAS baby. Okay, so echo has been done. We have done this echo. These are the echo findings. Fine. Moderate pulmonary hypertension. When we say it is moderate, your PA pressure is estimated by TR jet is 56. So what 56 means? 50 was the reading and we add on the 6. That is a RA. RA is that is your right atrial normal stationary pressures. That is 6. Okay, so it is 56. So what that number 56 means to you? How you quantify, just on the basis of TR jet, how you quantify your pulmonary hypertension? So mild to normal is less than 30. 30 to 70 is moderate. More than 70 is severe. So this is 56. That's why we call it moderate. Just on the basis of pulmonary TR jet. That is one criteria. Okay, that is not the sole criteria. That is one criteria. Fine. Next thing is the PDA is 2.3 millimeters, shunting predominantly left to right. So what is important in here? Your PDA is open 2.3 millimeters. Okay, fine, good. But we are suspecting moderate to severe pulmonary hypertension and PDA is purely shunting left to right. Does that explain something? Sir has told subsystemic pressures. Because normally when we see the reports, isn't it? One thing is, we see whether the pulmonary pressures are subsystemic, systemic, or hypersystemic, suprasystemic. Okay, subsystemic means your right-sided pressures are lower than your left-sided pressures. So if the PDA shunting is there, it will be purely left to right. 1. 2, systemic, there will be bidirection shunting. Third is suprasystemic. Majority, like more than 70% of the cardiac cycle will be, the shunting will be from right to left. Fine. But there is a catch here. I will show you one slide. That there is a condition in which there is not anatomical condition, physiological, that your pressures may be very high, and if it is shunting left to right, what does it mean? Okay, we will talk to that. We'll come to, pardon? Yes. So what he's telling is RV dysfunction. Okay, I will come to that. You will keep this in mind. Okay, fine, great. So PDA is 2.3 millimeters shunting left to right. PFO 3 millimeters shunting predominantly left to right. Predominantly left to right. Fine. RV and LV both are dysfunction. FS is 22%. Is it normal, low, high? So it is less than 25%. It is low. So there is LV dysfunction is there and RV dysfunction was there. Fine. This much is the echo report for the time being. We know about the ventilation. We know about the X-ray. We know about echo finding. Fine. So based on this, anything you want to change in this baby? Any additions, deletions from the management? Sildenafil okay for? Inodilator. Okay. Inodilator. Fine. Anything else? Okay, fine. Let's see. So I will just first thing is, we discussed that PPHN, okay? So this is what is the PPHN. I won't discuss there. Now next line is inotrope you want to choose, okay? So then with this echo report and everything in mind, this is a list in front of you. Which one you want to pick up? Low dose adrenaline, okay? Anybody wants to differ with this? Milrinone, okay? Yes, the sir is telling VP is low, and he's right. And even the diastolic blood pressure is low. See, if I give you a choice of dopamine and dobutamine, which you will choose? Dopamine. Okay, fine. Because the blood pressure is low and the dobutamine is vasodilator. But then the controversy is, if I start dopamine in babies with PPHN, it causes it increases your pulmonary vasoconstriction. It will increase your pulmonary hypertension. Okay? So that is one controversial thing. We will come to this. Then, next thing is milrinone. The counterproductive point is that the BP is low. Okay? Fine. Next thing is, set is adrenaline, non-adrenaline. Okay? And the last thing is vasopressin. Very few units they use, but it has been shown to have good results in PPHN. So how we will decide this? Based on your echo. See, in PPHN, studies have clearly shown that dobutamine in babies in PPHN with cardiac dysfunction, dobutamine is a better drug and preferred drug to be used as compared to dopamine if the shock or issues are because of pulmonary hypertension. Okay, that is one. That is what evidence tells. Okay. Now the CA thing is, this slide will explain the things. Okay, I will try to explain it. That how you manage shock and PPHN and shock. Okay, how you do it. Now, this y-axis, cardiac dysfunction, and cardiac function is normal, this section. X-axis, BP is normal, BP is low. Fine? Okay. Now, if your BP is low, but your cardiac functions are normal, treat with the standard nitric oxide. Okay? If you don't have nitric oxide, then you can start with adrenaline, non-adrenaline, vasopressin, and start. Again, this is one condition except for ELBWs where you should have a lower threshold to start with the hydrocortisone. Clear? If your blood pressures are low, 5 is a loading and then 2 mg is maintenance. Blood pressures are low, your cardiac dysfunction is there. The standard nitric oxide, then milrinone and adrenaline. Here your milrinone comes in with hydrocort. Fine. If your blood pressures are low, cardiac functions are low. If it is just PPHN, you can start with sildenafil and nitric oxide or any one of these. Normal blood pressures, cardiac dysfunction. Standard nitric oxide, no nitric oxide, then milrinone. Clear? Now I will come for duct when I was talking about duct. This is what we do in our NICU. We start with dobutamine or sildenafil initially. Then our choice is vasopressin. We have got a lot of experience and studies for vasopressin. So I personally use vasopressin and then comes to epinephrine or norepinephrine. But now people use more of epinephrine and epinephrine, norepinephrine. Now, what I was talking about, PDA shunting and atrial level shunting and PDA level shunting. So here, x-axis is PDA level shunting, y-axis is atrial level shunting. Fine? This PDA level shunting right to left to right. Atrial level shunting left to right to left. Fine? Then we will try to fit our baby in this. The first is this. Your atrial level shunting is right to left. PDA level shunting is left to right. What does it mean? It means that it is a duct-dependent pulmonary circulation. Clear? Your atrial level shunting is right to left. It means something is blocking the outflow of the right ventricle. That's why all the atrial blood is going from right atria to left atria. So it is right to left. But at ductal level, it is pure left to right. It means that whatever the blood the lungs are getting is all getting through the duct. So it is a duct-dependent pulmonary circulation. Clear? But in our baby, it was all left to right in both PDA and atrial, isn't it? So that our baby does not belong to this. Clear? Great. Next. PDA shunting is right to left. Atrial level shunting is right to left. That is very simple. It means what sir has told, it is suprasystemic right-sided pressures. All the shunts are right to left. So it is severe PPHN. What I need to do is, I need to start something for pulmonary vasodilatation. Nitric oxide, milrinone, sildenafil, whatever is available for me. Clear? Whatever baby is not like this. As sir told, there is no suprasystemic pressures. Then comes our atrial shunting is left to right, PDA shunting is left to right. Okay? So that means the whole issue is there in the lungs. It is a PPHN, but lungs are mainly affected. Again, our treatment is one, do the proper ventilation recruitment, what sir told, and then to think about surfactant. There is an issue in the lungs. You have to recruit the lungs properly. Does our baby falls here? Yes. My baby falls into this category. Clear? Now you understood. Next come this. When your atrial level shunting is left to right, your PDA level shunting is right to left. This is exactly the opposite of this. Fine. Your atrial level shunting is left to right, your PDA shunting is right to left. Then that means your LV is dysfunction. So this is a baby in which if you start nitric oxide, the baby will deteriorate. So that's why before starting nitric oxide, your echo assessment is very important. In this baby, if you start nitric oxide, the baby will deteriorate. So you have to, okay, what you have to do is, you have to do something which will augment the functioning of LV, support your LV. Okay, the nitric oxide is contraindicated in this baby, till you get this finding. Clear? Now you are clear in managing the babies with PPHN and shock. How you have to use that echo finding in deciding your treatment. Clear? I think so we should stop.
Thank you. No, thanks to all our faculty, starting from Dr. Mohit sir. We've given excellent video demonstration of mainly echocardiography assessment of all scenarios. It went very well. I hope you got something out of it. You're all going with some take-home messages. I would like to thank Dr. Mohit sir for your active contribution in this workshop, sir. Thank you. Thanks a lot. I would like to thank Dr. Vikram, our pediatric cardiologist, and given excellent and very informative talk on coronary heart diseases. And then he contributed in work sessions as well. No, thanks, Sir Vikram. No, thanks for your contribution. And Dr. Bujata, our consultant neonatologist. She's very experienced neonatologist, and you did excellent job in demonstrating and the echocardiographic demonstration of PPHN. Well done, Dr. Bhuja. And all other our faculty members and Dr. Venkatesh, he did so well in demonstrating PDA. He did excellent job. And other faculty members who helped in organizing our things, Dr. Revant and other team members. So, thanks to all, last but not least, thanks to all the delegates, we've waited and, I know that there were some technical issues, some problems with network connectivity and all. But I think in the end it went very well. I'm hoping that you're all going with some take-home messages. Okay, thank you one and all. I'll conclude the meeting. Thank you. Last but not least, thanks to all the organizers of Central NNF and Dr. Ananya and other organizing team. I think you did a fantastic job. Thank you. Thank you.